Good morning, good afternoon, good evening, wherever you may be. My name is Dr. Ambrose Talisuna. I work with the World Health Organization at the regional office here in Congo, Brazzaville as Program Manager for Emergency Preparedness. I will be moderating this session where we really want to have an update, guidance on the country teams on COVID-19, but with specific focus on the international health regulations, points of entry, population movement, and migration. And I'm glad that we've been joined in this webinar. WHO, all the three levels, the University of New Mexico, which is co-hosting this with us, ICAO, CAPSCA, and the organization and IOM. Before I give some opening remarks on the status of the outbreak and what we have been doing in the continent, let me invite Bruce, our co-host, to give some housekeeping rules. Over to you, Bruce.
Great. Thank you, Ambrose. Just sharing my screen. Hopefully you can see that. So welcome, everyone. Just a few logistic issues. There is interpretation available in French and Portuguese. There's a small little button in the shape of a globe down next to the Q&A button, and there should be both French and Portuguese interpretation available for you there. Please put your questions in the Q&A function in the little button in the lower Zoom bar. Let's try to use the chat function more for technical and logistic issues. This session is being recorded and your attendance is consent to be recorded, so thank you for that. The slides and a link to the video recording will be shared after the session via an email to everyone that registered. So we'll be sending that out within a day or two at the latest. And welcome to this WHO AFRO session on COVID-19. Thank you, Ambrose. Back to you.
Thank you very much, Bruce, for those housekeeping rules. Colleagues, as you know, the outbreak is evolving really fast. I think the window of containment is rather closing fast for the African continent, and we need to be doing things. Cumulatively, we are probably close to 47,000 cases, about 1,900 deaths have been reported in the continent for both AFRO and AMRO. And of these, of course, about over 30,000 deaths in AFRO and over 1,000 deaths, over 30,000 cases and over 1,000 deaths, which comes to a case fatality ratio of about 3.7. On average, we are seeing about 1,000 cases have been reported daily in the region during the last 7 days. But also we think that there are issues about testing because 69% of the reported tests in the region have been conducted in just 4 countries. South Africa with over 40% of the tests, Ghana 18% of the tests, Uganda 6%, and Rwanda 5%. Namibia, Seychelles, and Eritrea have not reported new cases, at least for the last over 14 days. So there is some window there that we could be seeing some light in some countries. Yesterday, WHO joined Resolve to Save Lives, the Africa CDC, the World Economic Forum, Ipsos, and Novita, which are market research companies, to launch a report titled Responding to COVID in Africa Using Data to Find a Balance. The report brings together findings from a survey conducted between 29th March and 17th April 2020 in 28 cities from 20 countries. And this research is really should inform our moving forward on the public health, social, and physical distancing measures. The report notes that awareness of COVID-19 is almost universal, but there are misconceptions, particularly in relation to treatments, how the virus spreads, and the source of the virus. 32% of the respondents say that they do not have enough information on COVID-19. 62% anticipate COVID-19 will be a big problem nationally, but only 44% think they may be at high risk of catching the virus. Opposition to public health and social measures was generally low, and opposition was greatest to shutting down markets, across the sub-region and workplaces. People reported high barriers to stay-home measures, namely running out of food and water, especially in West and Central Africa, and running out of money for over 60% of the respondents in West Central Africa. 59% of the respondents say they lack physical space to isolate sick people. So as we do our homes isolation strategy, we need to tweak them to maybe community isolation facilities. The report made 3 major recommendations, which I would like to share before I introduce this panel session. That while case loads remain low, African countries need to build health capacity to test, trace, isolate, and treat cases. This is really the foundation for us to be able to reopen society early, which has a bearing on this webinar that we are going to have today. Also, countries need to monitor data on how the public health social measures meet the local COVID-19 conditions and needs, and to determine when and how to lift them in a way that balances the lives and livelihoods of the communities. And finally, we need to engage communities to adapt the measures to the local context and effectively communicate about risk to sustain public health support to achieve widespread adherence and shield vulnerable population. So really with those opening remarks, I would like now to open this session, which is very exciting. We have a packed agenda, and I'm going to request all our panelists to stick to the time that we have allocated you. We are going to have a first session looking at IHR core capacities at points of entry with regard to COVID-19. Then we look at population mapping for prioritizing ground crossings for preparedness and response, and then look at entry and exit screening practices for infectious diseases among travelers. And then we look at detection of imported COVID-19 cases, and we can see this in East Africa, where I think the transmission now is being driven by truck drivers. And then we'll go to a discussion and Q&A session. So like Bruce said, please put your Q&A, we'll have a session to discuss. After the first Q&A session, we'll then look at WHO guidance on the management of ill travelers, management of communicable disease posing a serious public health threat in aviation, air ambulance, repatriation steps, and considerations for infection prevention and control in aircrafts. We'll then have another Q&A session, and then we'll go to the final section of the webinar, which looks at IPC related to cargo and International Maritime Organization collaboration with WHO to address COVID-19, and then health border mobility management, addressing public health along mobility continuum in the context of COVID-19. And we're really glad to have our IOM colleagues. We've been working closely with them in the East Africa on this. And then finally, we'll have POE available resources at WHO, Geneva, and AFRO. And then we'll have a final Q&A session. So with those opening remarks now, I'd really like to invite our first presenter, and that is Mary Stephen, who is the technical officer in charge of IHR. Mary, over to you.
Thank you, Dr. Talisuna.
Mary, we are not hearing you, so you better move close to your microphone.
Yes, just one second. Just 1 second. Sohan, can you give to Hortense interpreter link?
Yeah, I'll just look for her.
Okay.
Okay, Mary, can you please put your slides in PowerPoint mode?
Yes, can you hear me now?
Yes, very well, very well.
Okay. So good morning all. I'm not going to go into the AP update. This is just a graphical presentation of what is happening across the region. Dr. Talisuna has done justice to the AP situation in the region. So in AFRO, we have 46 of our 47 countries are currently reporting COVID cases. Only Lesotho has no case on the region. And if you put AFRO and EMRO together for all the African continent, we have 53 countries currently reporting COVID cases. So now, before we deep dive into the COVID situation, we need to take a step back, just one step back, to understand why we do what we do at the points of entry. So this goes back to the obligation of member states under the international health regulations, which requires all member states to build core public health capacity to prevent, dictate, and respond to public health emergencies without interference or significant interference with international trade or travel. So these are some of the general obligations. So I will suggest that when you have some time, just go through the IHR 2005. If you just Google International Health Regulations 2005, the 3rd edition, you will see provisions for the points of entry from Article 19 down to Article 41. It has all the provisions you will require under the International Health Regulations. So under the International Health Regulations, the IHR core capacity for points of entry, we have two major requirements. So there are capacities for routine, that means at all times, where countries are expected to build these capacities. So some of the things that countries are supposed to do is to do assessment and medical care of ill travelers, of course, provide the staffing and equipment required, and for them to be able to transport these ill travelers to designated health facilities, and have a trained personnel for inspection of conveyances, provide a safe environment for travelers. So looking at safe water, food, waste, and inspection programs, and also train staff for vector control. So we monitor these capacities under the international health regulations, and countries do report on how they are progressing.
Et les pays font rapport
annually to the
sur les progrès
party annual reports.
De façon
so
annuelle,
now,
ceci dans le rapport des parties.
For capacity during public health emergencies of international concern.
Que les pays pour faire face aux urgences sanitaires de portée internationale.
Yeah. Hey, Soham, can you please reassign the interpreter? The French interpreter is on the English line. Can we make sure the French interpreter is on the French line?
Sure.
Let's get that sorted before we continue. Hang on, Mary. Soham, go ahead and let us know when things are sorted.
Yes, it has been done. Thank you.
Thank you. Can I continue?
Yes, please, continue.
Yes, so for capacity requirements for responding to public health emergencies of international concern, of which COVID is one of them. So we have the following capacities: public health contingency plan. So countries are supposed to develop a contingency plan for their POEs, identifying the competent authorities and all the relevant stakeholders involved at the POE, and also the capacity to provide assessment and care of affected travelers and or animals, and then with, of course, arrangement of how to manage, treat, and refer some of these patients or suspected cases. So Ningla will go a little bit into these items. I just give us the overview. So we also need a capacity to interview suspect or affected cases at their points of entry. So space, we need to provide separate space from other travelers to do further interview of these cases, and of course the potential for isolation and referral of these cases to designated facilities that are supposed to be identified prior to the emergency situation. Then assessment and quarantine of suspected travelers. Like I said earlier, it should be in a facility that has been identified close to the points of entry, and also to apply recommended measures for disinfection, decontamination, and also deratting. Then to apply exit and entry screening. So there would be a presentation on this. I'm not going to go in depth into this for passengers, both departing and arriving passengers. And also, like we said earlier, transfer of travelers with suspected infectious disease to designated health facilities. So it means we need ambulances with drivers and ready to move at any point in time they are called upon to respond to any public health emergency. Another important issue that we need to take into account is the issue of coordination and communication during a public health event. So how the international coordination and communication takes place between different competent authorities at the points of entry, and also linkage with the different countries that might have been affected or could have interest in that particular case. The national communication. So we always recommend that the capacities at the POE, the surveillance has to link to national surveillance system, and it goes to the kind of reporting to the integrated disease surveillance and response that we have in the region. And of course, the national IHR focal point communicating this event both to WHO, regional contact points, and also to the neighboring countries. Then direct operational link with other senior public health officials, communication with the conveyance operators and travelers, and providing the related information, procedures and legal administrative provisions to conduct inspection and receive reports of cases of illness and other evidence of public health risks on board arriving a conveyance, communication and dissemination of information and recommendation received from WHO. So, and also collaboration between all the different stakeholders at that point of entry. Finally, assessment of all reports of urgent events within 24 hours. And after this assessment, this report has to be communicated to the relevant authorities. So going back to COVID-19, Africa, WHO AFRO, we started receiving cases on the 25th of February in Algeria. And then the first case on the continent, which was Egypt, was reported on 14th of February. So before we started having cases, when the public health emergency of international concern was declared, we did a quick assessment of readiness status for all countries across all the different response and preparedness pillars. Some points of entry is one of those pillars that we assess. As you can see from these maps, this is the status of the country as at that time when we did the assessment. So the average score for points of entry was 70%. So basically this assessment focused mainly on the capacities for responding to public health emergencies of international concern. So at the moment, countries in Africa started with entry screening of travelers coming from high-risk countries, but they continue to modify some of those measures given the evolution of the cases. So they moved to closing all their borders, and right now they are implementing lockdown, domestic lockdown in most of the countries. But currently we have, like you heard from Ambrose earlier, issues with the ground crossing, the movement of truck drivers carrying COVID-19 cases, most especially in the East Africa Community region. So the experience from Africa, we started getting our cases, and surprisingly, our cases, the initial cases didn't come from China. Most of our cases started coming when countries in Europe started having community transmission. So we got the very first case was from Italy, and then France, and quite a number of countries. Then the US joined Iran and different countries. So most of the cases were imported into the country, but one of the things was that these cases were not necessarily dictated at those points of entry, for the simple reason that most travelers arrived in country asymptomatic. So there was no how they could have been picked as suspected cases, and then they developed symptoms some few days after arrival, reported to health facilities, and they were picked by the national surveillance system in countries. So most of the challenges we have right now, as I said earlier, the borders are closed in most countries in Africa, but we have issues with ground crossing in East Africa, where truck drivers are still allowed to move with food and goods. And also some countries are having issues with unofficial ground crossing. So what are the strategies that we are using for Africa for the points of entry as one of the response pillars for COVID-19? So some of the issues, if you look at it, they are actually part of the requirement for emergencies under the IHR capacity requirement. So to support implementation of public health emergency contingency plan, and of course, multi-sectoral coordination at the different POEs. So ideally, they should have a public health emergency contingency plan, but where you have a POE without that plan, the first thing to do is to help them develop that plan first, and then we start implementing. So under preparedness, they should have had the contingency plan, conducted a simulation exercise to test the plan before an emergency occurs. But right now, we are right deep into the emergency. And so we have to just expedite action to implement the plan where it is available, or to update and adapt with the new current evidence available, and to support the different multi-sectoral coordination. Building capacity for POE screening, isolation, and management of ill travelers, and ensuring that there is linkage with national surveillance system. So Lingland is going to talk more on the management of ill travelers, and there is also a presentation of POE screening, so we are going to see the details in there. Establish a mechanism.
Mary, you should be winding up, Mary.
Okay, so establish a mechanism for follow-up of asymptomatic travelers. So this is one of the major challenges we have in Africa. Like you saw from the initial presentation, most of the cases arrive asymptomatic. So we have to find a mechanism for making sure that we are following them up, so that if they develop symptoms within the 14 days, they can quickly be isolated and tested. To establish a mechanism and procedures for communicating information on ill travelers between relevant stakeholders, and also aviation, such as aviation and airline authorities, and maritime authorities for the seaports. Establish a mechanism and procedures for communicating information. So basically risk communication at the points of entry, making sure that we provide the relevant information to travelers and also airline staff, rapid assessments of travelers, and making sure we have isolation facilities to assess and also transport these travelers to designated health facilities for further evaluation and testing. And also the last one is to monitor and evaluate the effectiveness of these measures, so that we can adjust as appropriate. So in conclusion, to reduce the risk of international spread of COVID-19, we need to strengthen or enhance interventions at the points of entry and follow-up of travelers upon arrival. I would like to say that countries should build on existing systems. From the assessment you saw earlier, the readiness assessment, we have a lot of green. But if you look at the IHR capacities in the state party annual reporting, we have more reds than green. So this is why we need to build on existing capacity, and these capacities, we can use them for future outbreaks. Interventions at the points of entry need to be strengthened as the countries begin to ease the lockdown measures in place to prevent resurgence of cases. We need to collaborate both within the region and internationally to prevent or to limit the international spread of COVID-19. And just a reminder that a threat to one is a threat to all of us. So the importance of collaboration. Thank you very much.
Thank you very much, Mary, for that opening remarks on the IHR. And we will go straight to our next presenter, and that is population movement mapping. And Teresa, please, you have the floor now. Over to you, Teresa.
Thank you very much, dear colleague, for this opportunity. I hope you can see my screen.
Yes, put it in presentation mode. Thank you.
All right. Thank you very much. So I will take this opportunity to provide a short presentation on the other side of measures implemented at POE. And this will focus mostly at ground crossings where screening may be more challenging to be implemented because of how people move across borders, especially when borders are porous. So this is just a very quick background. We have seen throughout centuries how population movement can contribute to the spread of diseases. And in most settings, actually, population movement would happen not through well-regulated airports and seaports where you have facilities available, but a lot of this movement actually happen through unsupervised ground crossings, where therefore then the detection of cases and the implementation of important measures is more so a very brief summary on IHR and population movements. What I would like to highlight from this slide is the fact that population movement is just so much more complex than border crossings through regulated points that I've already mentioned. And the reality is that borders are porous and border crossings frequently takes place unsupervised. There are also border communities who live across these international lines, and for them, these administrative lines may not mean so much. Therefore, understanding population movement beyond border crossing is more important for public health. And this is particularly important to identify locations and communities that are at higher risk of COVID-19 transmission in the context of this outbreak. Population movement mapping has been done in other outbreak contexts, and this is the experience that we would like to share and how it may be applicable as well for COVID-19 response. So I would like to highlight the experience of responding to the Ebola outbreak in the Democratic Republic of the Congo. And you can see on the map the number of ground crossings that are present between DRC, South Sudan, Uganda, Rwanda, and Burundi, which are where the outbreak took place, so in the provinces of North Kivu, South Kivu, and Ituri. So we see a very high concentration of ground crossings. Many of them are not IHR designated and therefore are not necessarily equipped with the necessary measures. In addition to this, these borders are also extremely porous, so people can still cross the borders outside of these ground crossings, and these can be done unsupervised. So the approach that was implemented in DRC and that we are taking forward in for COVID-19 response is to proactively map population movement, especially cross-border population movement. And by mapping these movements and the dynamics of the flows, the characteristics of the traverse, we can better understand where to put our measures. Maybe it is not at the ground crossing itself at the borderline where screening needs to take place, but rather at the entrance of the market that is located not far from the border where everybody congregates regardless of where they cross the borders. So the methodology for population movement mapping was developed together by WHO, IOM, and the National Health Border Program of DRC, the Programme National d'Hygiène aux Frontières of the DRC. And it was implemented throughout the 9th and 10th outbreak, actually, of Ebola in the country. And the mapping exercise is basically implemented through group discussions with key informants that represent different sectors: health, non-health, formal, informal. And so the multi-sectoriality of the audience itself is extremely important to facilitate discussions and more a sense of ownership of the response itself. So topographic maps are used to guide the discussions, and the aim of the mapping exercise is basically to be able to collectively agree on which ground crossings are most important because of the volume of travelers passing through these, or because of their connectivities with affected areas, and which communities therefore are connected to the ground crossings where measures need to be strengthened. So the experience in Congo has resulted in the identification of priority sites for interventions. What is quite unique in this experience is that measures, including health screening, was put in place not only at the points of entries, at the international ground crossings, but also at various internal points where we know that cross-border travelers congregate, and therefore then the risk of virus transmission may be just as high as at the ground crossing itself. And so up until today, 109 POEs and POCs, so POCs refer to the internal points, were put in place. Many of them have been deactivated since, with the significant reduction in number of cases, but some of the critical ones are still in place, and we evaluate which POEs and which POCs are critical, always based on this population movement dynamic information. So in each of these points, what is being implemented is traveler screening. So beyond measurement of temperature, there is systematic questioning of signs and symptoms as well as potential exposure, because towards the end of the outbreak, there was more emphasis as well on trying to identify contacts of EBD cases who are on the move. It's also a great opportunity for risk communication with the travelers to make sure that they have the necessary information should they develop signs and symptoms that are suggestive of Ebola, as well as local community engagement. So all of these POEs and POCs, so these points of screenings, are located within communities who are faced with the same risk, because they are also in contact with travelers who may be from affected areas, and therefore the presence of the screening points is also a good opportunity to engage communities to understand better what their risks are and how to better mitigate this risk. And so through the screening, then there's of course the management of alerts and the tracing of contacts later into the outbreak response. At the POEs, then the presence of these teams also facilitate cross-border collaboration. So this experience in DRC and with Ebola has resulted in 30 positive Ebola cases being detected. So 9 cases were detected at one POE, so an international ground crossing, but the other 21 cases were actually detected internally. So they were on their way to the border, they were going to cross the border, or they may be moving from North Kivu to South Kivu, for example, and passing through one of these important congregation points, and they were detected at these 11 POCs. So so the next 2 slides, this and the next one, illustrate how the mapping exercises are reflected in the maps that are subsequently produced. So it really shows the movement flows. Because population movement is something that is dynamic, and so the movement flow itself needs to be described and illustrated on the maps. And the good thing about using topographic maps to guide the discussion is that the answers can be recorded directly on the maps. So people are more engaged because they see, they visualize how people move, and they can identify directly on the maps and agree together. Then it's a collective consensus that is being reached on which communities, which areas, which border crossing point is therefore then the most vulnerable based on size of flow, so number of travelers, as well as connectivities.
Teresa, you have 1 minute.
All right, thank you. And so this is just another example of how the mapping exercise was done in Goma and the extensive cross-border flows as well between DRC and Rwanda, as well as Uganda, north of Goma, is taking place, and therefore then how much we need to be able to quantify the risk of importation, exportation of the virus based on these very large flows of travelers. So the public health considerations and action points that we have managed to capture are the following. So the results of these population mapping exercises inform the allocation of financial, human resources, as well as materials for EVD response, specifically at targeted points. The identification of these priority points was important considering the challenges of border control, especially when borders are porous. This approach contributed both to preparedness as well as response actions, because neighboring countries were able also to strengthen their preparedness measures based on the information that were provided from DRC. The participatory approach of the exercise favored ownership of those affected, and it also enabled that multi-sectorial collaboration as the exercise is implemented. Significant challenges remain, including staff training, supervision. We've learned a lot of lessons during the experience in DRC. And of course, the borders will always remain porous, and this is a challenge that we need to be continuously addressed. So this experience in DRC and the context of EVD, we believe, are still very relevant, even though this time the disease is different, the mode of transmission is different. But the fact that people move through borders, many of them unsupervised, remains an important issue, and this is an approach that we propose to be implemented as well to better assess the risk to importation, exportation of the virus based on prevailing population movement trends. That's all from my side. Thank you very much.
Thank you very much, Teresa, for that. And I hope you'll stay online because there are a couple of questions coming up in the Q&A. We are now going to move to our next presenter. And this presenter will actually address two of the topics: entry and exit screening and detection of imported cases. So Barbara, please, you have 20 minutes for two presentations. So you back to back, and then we'll go to the Q&A session. Over to you, Barbara.
Thank you very much, and thank you for the opportunity to participate and present. I hope you can see my screen. Can you see?
Noted. Yeah, yes, now.
Okay. The first presentation is about entry and exit screening measures that were implemented between 2003 and 2018 in previous public health emergencies of international concern. I have to mention that the funding was from the European Commission Third Health Programme.
Barbara,
yes?
Barbara, it's perfect. Great. Thanks for putting that in presentation mode.
Okay. So about the definitions we used in this, my presentation is based on the results of a systematic literature review and also a scoping search of the literature. So for exit screening, we collected information published in scientific journals, and we appraised also the quality of evidence in order to identify what was the public health impact from exit screening and entry screening. For the definitions, I think it's not necessary to mention. Exit screening is a public health measure implemented at points of entry on travelers departing from a country with the purpose to assess the exposure to a biological agent and or presence of symptoms. And for entry screening is to assess the same exposure and presence of symptoms to passengers arriving to a country. So we tried to assess what was the public health impact and the cost effectiveness of implementing entry or exit screening to ports, airports, and ground crossings, and what are the best practices that were implemented. Here we can see in this table the countries that implemented entry and exit screening at airports, ports, and ground crossings. And we can see that we have only little evidence about implementation of exit screening. Most of the countries implemented entry screening, and this was despite the fact that entry screening was not a part of the WHO temporary recommendations. We can see also that most of the evidence that we collected concern airports, less ports, and less ground crossing. In this map, we can see countries that implemented entry and exit screening in a response to the first SARS outbreak in 2002-2003. And we can see that many thousands of passengers were screened through entry screening, but 0 of them were identified at points of entry. Here we can see another map with the entry screening measures in response to the 2009 influenza pandemic. Again, we can see the countries that implemented entry screening. Thousands of passengers, again, they were screened at the airports, but very few were identified as positive to the influenza virus. And here we can see a map with entry and exit screening measures in response to Ebola virus disease in between 2014 and 2016. We can see the countries that implemented entry screening and exit screening. Many countries screened, again, thousands of passengers, but 0 or very few cases were identified. Exit screening in the past public health emergencies of international concern was part of the WHO temporary recommendation for implementation in certain points of entry for specific time periods. And as we see, we have very small evidence for, as we said before, for screening at points of entry other than airports. Here we can see for between December 2013 and March 2016, the epidemic curves in the 3 affected countries and the time frames that countries implemented entry screening. And exit screening, of course, was implemented throughout the public health event. And we can see that most of the countries implemented entry screening that coincided with the peak. Exit screening measures for Ebola virus disease in the 3 most affected African countries did not identify any case and show 0 sensitivity and very low specificity according at least to the reports we found published on the internet. The percentage of confirmed cases identified out of the total number of travelers that passed through the entry screening measures in various countries worldwide for the influenza pandemic were 0 or extremely low. And entry screening measures for SARS did not detect any confirmed cases in Australia, Canada, and Singapore. We also searched the literature about evidence and if it is possible to delay introduction of a disease to a country. There was only one publication indicating a delay for about 1 week. But there are several limitations in this study because they didn't also assess other parallel measures that were implemented in the country. So we cannot say that this delay of 1 week was specifically due to the entry screening measures. From the literature review, we have found that despite the inability to identify cases at points of entrance and mainly airports, there are other side effects, let's say, concomitant effects of screening that could be important for some countries. And this is why they may decide to implement entry screening or exit screening. So the one is an opportunity for educating and informing travelers that are passing through the screening points, may help to discourage ill persons from traveling. They can link travelers with public health authorities by giving information on where to find, to look for help if they develop any symptoms. Other countries, they use it to obtain contact information of travelers arriving from affected countries. So this could help later for contact tracing. Facilitate rapid and appropriate clinical care for travelers if identified. Also, maintaining confidence of the public that air travel is safe. Enabling, of course, humanitarian and public health organizations to sustain travel to affected areas and help avoid a major economic, social, and international impact that even a single case from a serious disease could have. The adverse effect from screening is, of course, the high cost of screening measures. Human resources are needed, and the cost is high if it is implemented properly. And maybe this will prevent investing in other more effective measures in response to a public health event. May give to the public a false sense of security, but it may cause stigmatization of travelers under public health observation. The conclusions from this literature review, systematic literature review, is that for preparedness purposes and in order to be ready to respond to any unexpected public health event, all countries should have the capacities to implement entry and exit screening at designated ports, airports, and ground crossings. Exit screening measures could be prioritized compared to entry screening. Evidence from this review suggests that entry screening measures alone are not effective in detecting imported cases at borders, but may allow opportunities for raising awareness and educating the traveling public. There are difficulties in assessing the impact of border screening measures, and the decision about implementation of screening measures should be examined on a case-by-case basis after considering the disease and outbreak characteristics, the country's situation and the available resources, and compare the cost and the effectiveness of other alternative measures. Screening cannot give opportunities for health education and information strategies to travelers. Training is among the key issues for implementing a robust screening program at points of entry. Implementation of entry and exit screening requires planning, allocation of resources, and careful design and application of protocols. And decision makers should be aware and consider the limitation of screening measures. False declaration by passengers about exposures and disease signs and symptoms. So the effectiveness of this depends on how honest people are when they are completing questionnaires. Some people may hide their fever by taking antipyretics. Screening based on a fever body temperature measurement is not able to detect incubating or asymptomatic travelers, so these travelers will enter the country. There might be language barriers, and of course, false positive and false negative results from temperature measuring devices. Here you can see the contributors from this literature review. And now, just a few words about the process. The process is usually according to WHO procedures, published procedures, primary screening, where an initial evaluation takes place with the public health questionnaire, visual inspection for signs, symptoms, and temperature measurement, and if necessary, a secondary screening for further evaluation, including public health interview, completion of a more detailed questionnaire, temperature measurement, and medical examination. But of course, this depends on the disease. Detailed advice is given in this guidance from WHO. And here you can see some parts of this advice. A few words about the temperature measuring devices. There are different types. It is, of course, recommended to use non-contact temperature devices. What is very important is to use devices that have been tested and approved to be used as diagnostic tools to measure fever, and should be used according to the manufacturer instructions exactly, and to be tested for accuracy, frequently calibrated if needed. Complementing temperature screenings with visual inspection and health questionnaires may increase the performance of cleaning, of screening. For Ebola virus disease, a report from the ECDC, from the European Center for Disease Prevention and Control, estimated that for Ebola virus disease, even the best temperature screening scheme will miss up to 20% of febrile symptomatic Ebola virus disease cases. An algorithm has been developed to help in decision making. I think when you have time, you can have a look at this slides in detail. It includes specific steps and questions that can be answered that concern the event, the disease outbreak, the country and point of entry issues, the potential that entry and exit screening measures could have in the specific context of the public health event and the country, and what steps should be done after decision and planning. So for the public health events, if it is a cross-border disease health threats or a public health emergency of international concern, and if there are WHO temporary recommendations for entry-exit screening, then other questions about the disease, the virulence, the transmissibility, about the outbreak, extent, and what is the current state, and what are the modeling studies available that can help in the decision making, the country specific questions. If in the,
Barbara,
if
you have 1 minute, you need to be winding up.
Okay, 1 minute for both presentations.
Spent already 18 minutes and you had 10 minutes to present.
Okay, thank you. Recently, we developed sorry.
Pablo, I've lost you. I don't know whether it's only me, but I can't hear you.
Okay, can you hear me now?
Yes, please.
Okay. I tried to upload the second presentation. So for the second presentation, these are unpublished data. It's another study we conducted and concerned the first 50 days of the epidemic. And we started collecting data about countries that implemented entry screening measures this time for COVID-19. We searched the situation reports from WHO, ECDC reports, and the great literature to see how many imported cases we had worldwide and how many of them were detected through entry screening. And we found that the first, from 24 of January until 17 of February, airport screening contributed to the detection of 9.1% of cases, of imported cases with no detection place. Most of the cases of the imported cases were detected through the healthcare system. That's why the conclusion from this study, you can see when you have time the slides in detail, is that investment of measures should focus mainly to the healthcare system and to early identify cases and to inform the traveling public rather than screening measures. Countries that implemented very strict screening measures did not manage to stop imported cases and the outbreak. Thank you very much, and I'm sorry if I didn't respect much time. Thank you.
Thank you very much, Barbara. I would request all the panelists who have presented to probably switch on your video if you really have internet capacity so that our audience can see you. We are going to have a Q&A session. So those of you who feel that you've been rushed, I'm timing you, so I'm trying to make sure that we keep within the time and we have quite some time for Q&A because people are asking questions. And so we've reached the Q&A session, and these are the questions that for me I captured, and Bukare will tell me whether you've captured some in French. Mary, you have 3 questions you need to address. Can you provide some more detail about how the readiness assessment was done to reach the score of 70%? How was the assessment done? And is WHO going to periodically do this? And then the final question you have, which country is responsible for ensuring IHR compliance measures? Is it the country of origin or the country of arrival? Things like yellow fever vaccination. Is it the departing country or the country of arrival? The other panelists can also give. And Teresa, you have, I think, some considering porous borders. What is WHO's advice to countries that have closed all official borders? What is the porous borders, the countries have closed, but what is our advice? I mean, borders are porous. And then there was something from a colleague from IOM, I think Lisa Wan said, what are IHR designated points of entry and how are they designated? England, you might want to take on that one because I think this is a WHO thing. How are they designated? Because I think somebody from the IHR Secretariat needs to address that. It's a colleague from IOM who is at a border post. Is testing Liz and then for Teresa, is testing of drivers with or without symptoms effective? Do we have any evidence that testing of drivers is effective for detecting the virus? There is a question which is general about prophylaxis for malaria. Where should it be done? Entry versus arrival again. I guess I'll take this, given that my previous life I was in malaria, so I will explain that one. Most cases were imported, but they were not detected because they didn't have symptoms. What do we do when we have such issues for COVID? And then for the final presentation, Barbara, should we additionally be screening internally? Is this something that we can do, and who should do it? Port health or airlines? So internal within countries. And then there is something about, there is really uncertainty on the quality of infrared thermometers, temperature measurements. Is there any technical advice or technical document to be able to guide this? And then how do we address the challenge of asymptomatic cases for entry and exit screening? And then the final one for Barbara, because of POE closures, there are no travelers now, but only cargo. How do we use your study and your experience to deal with exit and entry screening of cargo? Those are the ones I captured. Bukari, if you have additional ones, please, you can, and then I'll allow the panelists to respond to the questions. And you can leave for me the malaria one and prophylaxis, because I used to be a malaria expert before I became here. Okay, over to Bukari. You have any questions from friends?
Yes, there is only one question for Teresa on the DRC experience. They want to know what was the role of the community in controlling population movement.
All right, so let's start with Mary, and then in case there are issues that we think are not very well clarified, especially on designation, I'll allow England to say something. Mary, over to you. And please, if you have a good camera, please let me make sure that we see you, because we want to see whether you are telling us the truth. Over to you.
Thank you, Dr. Talisuna. Okay, so I have two questions. One was on the readiness assessment, and the other one's on compliance, monitoring compliance to IHR. So for the readiness assessment, we developed what we call a readiness questionnaire. So it has different components: surveillance, we have POE there, we have coordination, we have case management, risk communication, laboratory, infection prevention control, and logistics. So there were key questions that we asked based on the requirement from the strategic preparedness and response plan. For the POE, like I mentioned earlier, the questions we asked were basically those IHR requirements for emergency response, for responding to public health emergency of international concern. So we sent out this questionnaire to countries, and the questionnaires were completed. The first assessment, we got all the 47 countries responding to the questionnaire, and then we did the analysis to see where we stand. So all the questions, answering the question on the score, the overall score. So all the questions were weighed. So the weighting of the question determines what indicator we are looking at. So with that, we had the average score for all the different capacities. But like I said earlier, if you look at the SPAR report, we have a lot more rates than we do on the readiness assessment. So it depends really on what the countries answered, and also because we didn't look at everything. We focused mainly on their readiness capacity, which was basically on the capacity for responding to public health emergency of international concern. So this is the readiness assessment. Yes, a second batch of the readiness assessment was deployed. They have collected data, but they have not received data from all the 47 countries. So this was the reason why I initially put the two assessment, but the later one had some countries without data, so it wasn't very good for comparison. So this was why I removed it until we get the data for all countries. But from looking at it from countries that have reported, some of those countries managed to improve those capacities. Some of the areas where they had red, they managed to move it to yellow or yellow to green. Then the issue of compliance, who is responsible arriving or departing country. For yellow fever specifically, it will be the countries where you are arriving. They will check for your yellow fever certificates mainly. Some countries do check on departure, but the arriving country has the responsibility to make sure that you do have the yellow fever vaccination certificate. Over to you, Dr. Ambrose.
Thank you very much, Mary. You covered all your questions. Teresa, over to you. If you are still...
Yes, I am. And thank you very much for the questions. Unfortunately, my internet connection is unstable, so I won't put down the video. Firstly, the WHO advise on borders that are being closed, considering that borders are porous. I think we absolutely acknowledge that closing and opening borders are decisions that national governments can make. It's absolutely within their authority. What we do recommend, though, is not to do so because or only to do it within a limited period of time. The public health rationale behind it is, or just the social rationale behind it, is because regardless of the formal closures of borders, in most instances, when people want to cross the border especially for critical activities, they will find a way to do it. And I think this is something that we can all acknowledge. I mean, even in Europe, it's happening. And so therefore, what is problematic with closing borders is normally because then all the measures that are put in place at ground crossings are normally also then lifted until the borders are open again. And also we tend to forget that when borders are closed, then it is much more difficult to then supervise the informal border crossings. While when borders are open, it's easy to canalize travelers to make sure that they can actually be properly evaluated if screenings are in place. So, but having said that, closing and not closing borders are within the authorities of every single nation to implement or not. Now, what we also need to be, before I move to the next question, is what we need to also be very mindful of is the need for people, especially those who need to escape their homes due to violence, due to humanitarian crisis, that these can also access or reach safe areas, even if it includes crossing the border. So when borders are closed and it prevents individuals who need international protection to actually obtain it, then this is extremely problematic. And I'm sure that other colleagues from other agencies, especially UNHCR and IOM, would also be then even the bigger advocates for maintaining borders open, especially for this purpose, to provide protection to those who need it. Now, secondly, testing of drivers. I think testing should still be framed within national strategies. So what testing, who are the targets of testing? For COVID-19, it's for those who are suspect cases. So whether a driver needs testing or not, it needs to be evaluated based on the case definition for suspect cases. Therefore, looking at symptoms of history of exposure, right? So it's not just like quarantining of international travels just because they happen to be coming from a country where there are COVID cases. This is not necessarily commensurate to the risk. And so testing capacities, especially in places where these capacity is extremely limited, we need to be extremely careful on advising mass testing. So bulk testing is normally not recommended. It really needs to follow the case definition for suspect cases, and only suspect cases would then be tested. And then the third question on the role of communities in controlling or in managing population movement. The key message here is population movement is not a bad thing. It may, in times of outbreak, contribute to the spread of diseases, but it has so much social and economic benefits that one cannot really be limiting a population movement, especially for the long term. And we have seen as well how countries, even the more developed countries, are trying very hard to lift their containment measures as well, those restricting movement because of the socioeconomic consequences from it. I think what's extremely important is that communities understand the risk associated with population movement, and therefore they are then in a better position to protect themselves. In the context of DRC, population movement, even during the peak of the EVD outbreak, especially movement for livelihood purposes to go to the market to buy basic necessities, this was never prevented. So there was a lot of engagement done to make sure that if somebody is visibly ill, that he or she can be directed immediately to somebody who can then raise the alert and take the necessary next steps. There was never any notion of completely stopping movement, even with Ebola. And so there was a lot of appetite in making sure that there's more hand washing facilities in communities, that there are messages that could be circulated around. Community members did ask for additional protection, but they also were appreciative that there were screening teams based in their communities to make sure that the travelers who are ill could be detected early on. Actually, in some instances where the point of control teams managed to identify positive EVD cases, it was because the community members referred these travelers to the screening team after they tried to deviate their routes to avoid the screening process itself. So it can be managed in a positive way. And I think on the IHR designation, yes, it's something that England would be in a better position to answer compared to me. Thank you, over.
Thanks very much, Teresa. Barbara, over to you for your Q&A questions.
Yes, thank you. So, there is one question about the use of infrared thermometers. I can say that I can share the full report with the participants, where you can find specific information for infrared thermometers. We have also prepared a list with the publications that we collected through this literature review. And we have a list with thermometers that were assessed in these studies. So we can share this as well. What is important for the points of entry is if they decide to use such an equipment, they should have standard operating procedures and train staff to use them. And to use exactly the manufacturer instructions, to test for accuracy frequently, to calibrate, etc. So to reduce the possibility to have wrong measurements. How do we address the challenges of asymptomatic carriers, particularly of COVID-19, at exit and entry screening? As we said, it's not possible to detect asymptomatic carriers at the points of entry. What you can do is to have information strategies in place so that these persons, if later they develop symptoms, they should know to self-isolate themselves and where to seek help. So the telephones in the country can be provided to all the persons that are passing through the borders. So they are aware how to respond in the country that they are visiting. Of course, it's very important to combine other measures, personal hygiene measures, personal protection measures. We should not rely, as we say, as we see only in screening. It can be as a supplementary measure, screening, and will not prevent, will not stop the disease, as we said, as we see, especially COVID-19. Yes, and then there is another question that now points of entry around the world are closed, and many countries now are planning the reopening of points of entry and how this study can help. I think it's a very good question. I think what is important is that each country decides on their own, considering their resources and their own epidemiological situation and the origin of incoming travelers. What could be worthwhile is exit screening at the countries that they have high ongoing community transmission. This will increase also the ability of this measure to detect cases when they are trying to exit a country. Also, another thing is that we should, in the decision making, we should separate the travelers from the staff of the points of entry and the staff of conveyances. So for the staff of conveyances and the staff in general in the transport sector, it is important to have ongoing health monitoring, including measurement of fever. But this should be looked separately from the general screening measures for the general public.
Thank you, Barbara. I think those were your questions. And England, can you say something about designation? Because if you can't, I will say, but I think I want to leave you to say it. So that is a question from a colleague in IOM. What do we mean by designation in the IHR context, England?
Yes, thanks. This is a question actually very frequently asked during the course of this 10 years of implementation of the IHR. So under the IHR, we have this designation for ports and airports. This is mandatory, meaning that all these ports and airports identified by countries for designated as a designated airports and ports, they need to develop the capacities according to Annex 1. Exactly the same, when Mary was introducing what are the set of the capacities required as the criteria for the designated points of entry. So that includes all the assessment for the travelers and water safety, food safety, waste management. So it's a full scale of capacities across different sectors and different disciplines. However, when it comes to the ground crossing, recognizing that ground crossing definitely has much more complexities than the other airports and the seaports. So these will require more public health rationale in terms of investment of the capacities and to address the priority ground crossings. So this ground crossing, designation of ground crossing is optional and based on the rationale, for instance, the travel volumes, the population movement, and the connection with the communities adjacent to the ground crossings, and also where this route originates from, and if it's the train, bus across the borders. So where this transportation originates from, and what are the routes, itinerary, and arrival where. So the epi situation along this route will be very much relevant. However, I think we need to bear in mind the designation is not a label that saying the other points of entry which are not designated, you don't need to develop the capacities, because diseases don't respect the borders. Regardless you are designated points of entry or not designated, if the disease comes, you need to have a certain set of capacity to cope with that. So I think the designation is just a way that to encourage the countries to take a stepwise approach based their resource capacities, so they can take steps to equip all their points of entry eventually to develop all these capacities. So just in a nutshell, so we still need to encourage all the points of entry, start little by little, gradually to build all capacities. Thank you. Over to you.
Thank you. I know in England you'll be coming back to this, yes, but it's a country decision. So England has explained that. The question on malaria prophylaxis, actually it is the traveler, the country from where you're coming from and going to a malaria endemic country, that should be responsible for you to guide you on what drug you should take. Malaria endemic countries already have malaria, so they don't necessarily have prophylaxis. But for people who are coming from non-malaria endemic countries, they need to take prophylaxis because otherwise they will get severe disease. So there is always a guidance from the country where they're coming from in Europe, the US, but actually it is really on the onus of the traveler to be sure that they are carrying their prophylactic drugs. So it is really the country of origin and the traveler, because where you are going, malaria is endemic. So that brings to a close the first Q&A session, and now we are going to go to...
Dr. Talisuna.
I am running out of time now.
1 minute. Can I comment on...
Mary, let me, the other moderators, there are people that we have another Q&A session, you'll comment, and some of the other presenters might address some of the issues, because in the interest of time, I'm running very short. So let me move on with the next presentation, please. So the next set of presentations now is on WHO guidance on the management. Ningland, you're speaking, and then Nika, you're speaking on the management of communicable diseases, and then we have air ambulance. So quickly, all the presenters now, the 4 presenters, you'll come in a row, and over to you, Ningland, now for the next presentation.
Oh, okay, thank you, Ambrose. But I have a little bit problem with finding my presentations and to share. I'm sorry, just give me 1 more minute. Okay.
You're going to make us see all your files. Eh?
Can you see the Thank you. My secret. Okay, anyway, can you see the slides now?
No, we see your file. You have not yet clicked on it.
Oh, God. I thought it's already shared.
Open the file.
Yeah, I already opened the file.
Okay, now.
Here. Okay. Can you see it now?
Yes, please go ahead. Put it in presentation mode, please.
Yeah, so thank you for the hiccup. Oh, sorry for the hiccup. Okay, so for my presentation, we have a very short time, so we will just concentrate on the main items that we have developed at the very outset of this pandemic. So it's related to management of air travelers at the different types of points of entry, plus the operational considerations for COVID-19 management in aviation, which was developed in collaboration with ICAO, IATA, and the ACI. So I just walk you through very briefly the main items, because you can see that, you can go through in detail in our interactive online courses, because all these guidance have been converted to the online interactive courses for you to easily digest the information in a more relaxed manner. So here, just give you a cursory look. For the management of air travel at points of entry, we basically address 4 major points, which is the detection, interview, and reporting, and also the medical referral and quarantine and isolation of the air travelers and their contacts. So for each item, we basically list out the planning phase and the implementation. So for the planning of the detection, what we wanted to address is you need to have a trained personnel, and they need to have a basic knowledge of how to protect themselves in terms of the physical distancing and also the PPE. And they need to have a non-contact thermometer measurement equipment. And also for the large volume of travelers, you need to at least have 1 healthcare worker, and to help if 1 air travelers has been identified. And then during the implementation, there's always similar approach: self-reporting, visual observation, temperature measurement, because we recognize that for airport or seaport, if you're doing screening, and that could, if we ask the travelers to fill in their travel health declaration in paper, this could generate the problem of a large crowd of people and without respecting the physical distancing. So instead of asking the paper collection of health declaration form, we encourage also the country to start to work with the partners and perhaps to explore the electronic data collection. So I understand that in AFRO, you already spearheaded this practice. So this is a very good approach, which will prevent the increasing infection because of the crowd of the travelers. And for interview of air travelers, so again, the planning phase, we need to have an interview space, and which will allow the travelers to separate at least 1 meter between each other, and a well-ventilated room and the arrangement with the local health authorities for safe transport and the further treatment assessment of the air travelers and their contacts. And also, of course, we need to have a supply of proper hygiene and PPE for staff, and also the cleaning and disinfection disinfectants. For implementation, I think many of the people here, the audience here, you're very familiar with all these procedures. I think, again, what we are interviewing the air travelers mainly are, again, the temperature measurement, which is similar during the EVD. We do the secondary assessment. So you look at their signs, symptoms, travel, contact history, additional observation. What I want you to highlight here is the travel and contact history. The questionnaire is based on the involving surveillance, WHO surveillance documents, which is in relation to the definition of close contacts. So we need to encourage you that to always look at the WHO surveillance guidance to understand what are the definition of the close contacts in order to be able to update your questionnaire. And during the implementation phase, okay, so I would skip that because this is, of course, almost a daily practicing at many points of entry. So I will leave that in case you have any questions, we can address that during the Q&A session. And for the communication, I think there's also some, you do it day and day night during this period, but I want you to address is, again, it's a part of the ITRA points of entry capacities is to use the ITRA health documents. For airport, for aviation, we have the health part of aircraft general declaration form, which is also part of the ICAO health document. And for the maritime, we have a maritime health declaration form, which will give you, as a points of entry health authority, some initial information for you to analyze, to have a preliminary assessment of what's going on board, so you can organize yourself to provide the technical assistance as needed. And then the other important piece is that points of entry need to build the connection with the national surveillance system. So you have a mutual two-way communication with the national surveillance system. So anything happened at points of entry can be picked up by the national level. And if national level, you have information that could impact the points of entry, that could be also related to the port health authorities. So that part is a quick overview on the management of air travelers at points of entry in general. So I will also speak very briefly on the management or outbreak in aviation, which will touch upon these 6 bullet points, the measures at airports, onboard aircraft, management of contacts, reporting between the aircraft and the underground health authority in terms of what's happening on board aircraft if there's an air person identified, and other public health measures of cleaning and disinfection, so on and so forth. So this is a snapshot that we got from our online interactive course. So just to give you, help you visualize what's in this guidance. So you will see the preparation because, again, going back POE is not only just talking about airports, ports, and ground crossing, the pathway. It's a continuum of pre-travel, during the travel, and post-travel. So we just want to give you this concept preparation before you travel, and during the travel on board aircraft, and when you landing. So no matter for the airport operator, aircraft operator, what we need to know to protect the employees' safety and to make sure there's a business continuity of the airlines once we can reopen their borders. And so again, they need to have a basic protection knowledge about in response to COVID-19, and when and how to use the masks, because the medical masks normally should be used reserved for persons with respiratory symptoms. However, we understand that the industries, they might take their discretionary measures. I just learned this morning that IATA, they have, thank you, Ansa from ICAO told me this information. And IATA is calling that all passengers wear, face covering, and for the crews and to wear masks. So this is a very much that based on their industry's decision. And so this will impact their, their practice in different airlines. Oh, sorry. And also they need to understand how to donning and doffing the PPE if somebody is ill on board aircraft. So the cabin crew will manage that case temporarily before landing. So they need to understand that part, PPE requirements. And if they develop signs and symptoms, they need to immediately seek the medical advice and to inform the airlines and the airport, because they are the airport and airline staff. So they will need to stop the operation and to alert their employee. Okay, and when the airline crew and when they are on the ground, and so they have a different arrangement. I know that maybe later ICAO and the other aviation colleagues that you know this also very well. So this is the paragraph we developed together with the aviation sector, basically to advise the crews that they need to avoid the rush hour when they're in the other countries that with community transmission of COVID-19, and to minimize their time spent in the public areas, and also personal hygiene, hand hygiene, respiratory hygiene, and self-monitoring is very important. If they develop fever, cough, or difficult breathing that are indicative of COVID-19, they need to alert their operator, their employees, so they know there is a situation going on with that staff. They need to take the actions. If then we, when the previous part is about when they do the preparation, when they're still on the ground. Now we are also in this guidance, we touch upon how to manage the suspected cases on the onboard aircraft. So this is basically derived from the IATA, the crew guidance for management of air travelers on board, which are very much suspected of communicable diseases. So we basically tailor that guidance into the COVID-19 situation. The main principle is to separate the air persons from the other passengers by minimum of 1 meter. Since we on the onboard aircraft, we basically can only measure by the seats, the number of the seats. So what we recommend is to at least to keep the 2 seats separate. And this is also in line with the studies that ECDC has been doing in terms of the MERS, and WHO is part of that. So basically for anybody who's ill, and then the space around this should be 2 seats or in all the directions. So if somebody is ill, then the first thing is to separate them 2 seats away from the others. And ask the air travelers to wear a medical mask and to practice the respiratory hygiene. Of course, sometimes they cannot tolerate a medical mask, so the other passengers need to be moved away, at least 2 seats away, and also wearing the masks. And designate 1 crew member to serve the air person, and also, if possible, designate 1 toilet only for this person's use. And then when attending to air travelers, the PPE requirements, these needs to be respected for the cabin crew who's assigned to attend to this air traveler. And also in terms of disinfect or cleaning any body fluid or spill of that ill person, the PPE requirements also need to be respected. And this part we have developed with great support from our RPC colleagues. Perhaps I think Clara, Maria Clara, I see that in your presentation, you may touch upon that part as well. So I will keep this very brief.
I think you should be winding down. You're running out of time.
Okay, so I will just skip it very quickly. And this part, we trying to weave the IHR requirements under this guidance, and to remind that the outbreak is just not to one person, it's actually to everybody. So everybody has a shared responsibilities, like the aviation authorities, aircraft operators, everybody has a role to play in terms of management of air travelers if it happens in aviation. So this is basically the reminder of obligation under the IHR for management of air public health events in aviation. And okay, then the guidance also touch upon the disembarkation of air travelers and different measures to the air travelers, their close contacts and the non-contacts. So you will see all the details. Just in the interest of time, you can find all the details in the guidance, but I will encourage you to participate in the online interactive course in the WHO website, which I will introduce in my last presentation in terms of existing WHO guidance and the training materials. So those the training online course will really help you digest all this information in a more interactive way, give you the Q&A quiz, give you the scenario for you to brush up on your knowledge that you got from the training course. So I would encourage you to go through that course rather than read the guidance documents, because we got a very good feedback from the learners, and they all consider that the courses is much better to absorb the knowledge. So yeah, you will see in the end for my last presentation. So I think I will stop here, not spending too much time on the details. Thank you. Back to you, Ambrose.
All right, Ninglan, thank you very much. We will just go straight to our next presenter. Nika, I hope you're ready to move as quickly as possible for that presentation, because are you online?
Yes, yes, Dr. Talisuda, I'm there. And, yes, can you hear me?
Yes, Nika, I can hear you. You have the flow. Please, you have
Okay,
10 minutes.
So thank you very much. I don't know if you can see my presentation.
No, we can't see your presentation. Please load your slides.
Okay, so you can see my presentation.
No, you haven't shared the slides. I see nothing.
Okay, let me see again. I thought I did it. I don't know what is happening.
Can we help Nika to share the slides? Bukari or Bruce, if you have the slide for Nika, we could share for him in the interest of time, because we don't want to lose time sharing slides.
Hi, Ambrose, it's Bruce. So Nika, can you click the share screen button at the bottom of the Zoom window?
Yes, I click on it. So
great, and then you should see, there you go. Great job.
Is it fine now?
Now just put it in presentation mode and I think you'll be all set. Perfect, thank you.
Okay, I think it's good now. Okay, so my presentation will be very short and summarize on how the aviation is organized to manage the communicable diseases posing public health, posing a serious public health risk in aviation. So this is the plan of my presentation. I will start recalling the ICAO requirements and then go in detail, very short detail, on how state airport airlines, air navigation services, and other stakeholders have to organize themselves. And then finish by recalling very quickly what is the CAPSCA program. So when it comes to aviation, we have the Chicago Convention, which is the foundation of the international civil aviation, which states very clearly the commitment of state to prevent the spread by means of air navigation of communicable diseases. And also state took under this Chicago Convention, so they under the Article 14 to keep in close consultation with the agency concerned with international regulation related to sanitary measures. So this is a quick recall of what the Chicago Convention is saying. So when it comes to ICAO, we have several requirements that are part of the annexes to the Chicago Convention. We have the annexes on operation of aircraft, Annex 9, Annex 11, Doc 4444, the Annex 14 related to aerodrome, and also Annex 18 on the safe transport of dangerous goods. And the previous presenters in England in particular mentioned some of the provision of these annexes. So I'm not going to again repeat what have been already said. So what we have to know when it comes to state is that states have to ensure that there is a close coordination, collaboration, and cooperation between public health and aviation. So it's very important when it comes to the management of communicable diseases. And as for that, establish and implement an aviation public health plan. I'm recalling it here because many states do not, as of today, have a well-developed aviation preparedness plan. So you have a template that is available on the CAPSCA website. You will find also a lot of provision and the guidance material on the CAPSCA website. You can take it, and this plan contains processes and also procedures on how to best manage these communicable diseases. So establish a rapid communication network involving all the stakeholders. The stakeholders are in the aviation industry and also outside the aviation industry. And also states should ensure that all the plans that are there are tested in order to ensure their effectiveness. When it comes to airport, England also recall it that airports should have emergency plan is mandatory, and the emergency plan should include a public health emergency management component. The airport authority have also to ensure appropriate communication with internal and external stakeholders as well as travelers on public health measures, and discuss with public health measures with the public health authority. So when it comes to screening, disinfection, training, and so on and so forth, in order to develop suitable plans and provide adequate facilities and equipment. They should also ensure that they provide a parking and adequate facilities for the management of an inbound aircraft. So it's important to emphasize that this parking should not be the isolated parking that is required for the management of security emergency. Here we are talking about the public health emergency, and an appropriate parking close to facilities should be available for the management of this situation. So facilitate the quick and efficient access to airport and aircraft to public health officials. When it comes to airlines, they have to develop and implement procedure to cover ICAO and WHO requirements as well as IATA guidelines. And they have several guidelines they can find on the IATA website. Cooperate with airport and public health authority with respect to dealing with sick travelers, baggage, cargo inspection, and logistics. Ensure that on board they have their universal precaution kit and general declaration form. Ensure that their crew and ground handling personnel are familiarized with their procedures and all the guidelines we are talking about. And also ensure to have appropriate communication system in place in order to communicate on all these measures. Now, when we have suspected place in flight, so the main service provider, the first contact is the air navigation service provider. So for them to manage the information, they have to develop and implement appropriate communication procedure to forward notification as soon as possible upon receipt of information from pilot. So for them also, they need to have their contingency plan in respect with what Annex 11 is requiring. So this is the diagram for the notification of suspected communicable disease on board an aircraft. And I'm not going to explain in too much detail, but you can see the en route controller receiving information from the aircraft. So he has to convey it to the departure and the arrival air traffic controllers who, via local procedure, have to forward the information to the appropriate authority, including public health authority. Now, at the airport, we have made several stakeholders, including custom, immigration, aviation security, cargo, and also airport workers. And England mentioned the case of airport workers who sometimes are forgotten in the chain. So what we have to ensure at the state level at the airport level is that they have to develop appropriate procedure for the management of public health events by these people in their daily duties. And this procedure have to be developed in close coordination with the public health authorities. And these people have to be appropriately trained and also on their procedure and also on the application of the measures that they have to follow. Now, two very quickly additional information is about states. So you know that today several states restrict their airport, so put bans on their airport and so on and so forth. So I just want to recall here that contracting states should not restrict their airspace to any aircraft for reason of awareness that an aircraft may have a case of communicable disease on board. So there are several NOTAM that are currently published by state. We are still following individually with state at the ICAO level to have some flexibility in their NOTAM in order to allow the continuity of a relief flight and also the cargo. For airport, ANSPs, airlines, and other stakeholders, they should also consider the reduction of their staff members because their staff members can be ill. So this should be part of their business continuity plan. And this is important to ensure the continuity of the operation at the airport in the COVID-19 environment. Just to highlight the CAPSCA program. So this program is a global program and we are working together with all our partners and also other UN agencies, including WHO. And the aim is to assist states with the implementation of the WHO IHR and ICAO public health related SAPs. So this program is still there, continue working with states. If you need an assistance, if you need information, contact the ICAO regional offices, and then we will be happy to give appropriate information or assistance. So I already mentioned the CAPSCA website. So visit this website, we'll find a COVID-19 that is a part of the website dedicated to COVID-19 information. You will have a lot of information coming from all the CAPSCA partners. Thank you very much. Over to you.
Thank you very much, Nika, and thank you for keeping in the time. So we'll go to the next presentation, and that's Lesego on air ambulance. Please, over to you, Lesego. Can you please load your slide and start immediately? Thank you.
Nika, remove your slide.
Lesego, you have the floor.
You are muted. You are on mute.
Hi, Bukari. We just trying to load this, connect the slide. Yeah. Can you see?
We can't see the slides yet. They are showing that you are loading. Double click to enter. You can't see the slides yet. Go to share screen and then you'll see your slides and then just double click on it. Yep, we can now see, put it in presentation mode. Thank you very much. Over to you.
Okay. Where do I press? Huh? Yeah. Okay, so my topic today is actually repatriation flights, and I will touch a little bit on your air ambulance operations due to time constraints. So in the last month of travel ban in South Africa, we've actually had about 285 repatriation flights from two international airports, Johannes O.R. Tambo and Cape Town International, both coming in and outside of South Africa. And based on our regulations, disaster management regulations, we were requested to actually develop guidelines for repatriation missions for our operators. As you are aware, the repatriation missions do not follow the normal process of actually airline booking. The arrangement is actually made between the international relations, the port health authorities, and the embassies. The embassies actually have their own medical doctors, in most cases, who actually pre-assess the passengers. What we identified earlier on was that this information was actually not shared with the airlines, and airlines were not able to actually prepare for high-risk conditions. For example, issues of stressors of flight where additional oxygen may be required were not considered by the embassies. So we identified this at the beginning, and one of the requirements that we had to come up with when we were developing the guidelines was to actually request the embassies to submit medical assessment information to the airlines so that they can better plan for the trip. Confirmed cases of COVID are not allowed on board of repatriation to actually fly with passengers. And pre-assessment at airports actually take place, and it's actually conducted by the port health authorities. In terms of cabin crew, initially we worked on volunteers. However, a number of airlines or operators are actually conducting repatriation missions, and they are using their normal staff. One of the issues that we do consider is that the crew should not have any underlying condition that may actually get compromised further in case they actually travel to a high-risk place. Some airlines actually conduct their own medical assessment prior to crew leaving on a repatriation mission. And in line with WHO requirements that actually England was talking about, that in these missions, there should be a medical professional. We require a minimum of one, and we've actually defined it to be either a professional nurse and advanced or intermediate life paramedic, or a medical practitioner. I must say most of the missions are actually done by professional nurses and advanced intermediate life support paramedics. Crew that has been identified as having close contact with a positive COVID case are relieved from their duties until they actually are cleared by the health officials. And they are required to actually declare whether they've had contact, and screening in terms of temperature is actually done. When we looked at various issues at our guidelines, we considered areas of risk. Within the airport, we looked at, where passengers and crew can actually get infected. It was basically en route to the airport or where they found themselves in public spaces. Before boarding the aircraft, normally at security, those areas are normally congested. In line at check-in counters, you can see most of the time they actually congested. Waiting areas via the jetways towards the aircraft, and on the buses. So we looked at areas that are normally crowded, and measures were actually put in place to ensure that there's social distancing in place, especially in highly confined and full areas. We also considered the fact that some of the airlines said to us, but why are you so strict? Because most airflow on board an aircraft is actually laminal, and you need to worry about 2 people, 2 rows in front of you and 1 meter apart. But we do know that with respiratory illnesses, it has been demonstrated during SARS-1 and some of the respiratory illnesses that you can find actually cases that were sitting far away from the index case. Hence, we decided to actually put additional measures to the normal requirements. We know that we actually have HEPA filters on board an aircraft, and that's one of the questions that were asked. And we acknowledged and we talked to both Boeing and Airbus, who confirmed that most of the modern aircraft actually have HEPA filters, and filtered up 99.9% of the fungi, bacteria, and viruses, and also coronavirus, looking at the previous studies that were done. We emphasized to the operators that they had to actually change their HEPA filters in line with the procedures of IATA, as this can actually pose risk for those who actually maintenance guys who change their filters. We looked at measures in place, universal precaution kits, and we've made sure that our universal precaution kits are actually in line with the latest IATA guidelines, which has actually amended them further to what used to be on universal precaution kits. On board an aircraft, obviously, cabin crew are required to actually wear their masks all the time, and passengers are required to bring their own masks, and they have to be wearing masks all the time. Temperature monitoring for long-haul flights every 4 hours has to actually be done using, obviously, a non-contact non-contact thermometer, so that you maintain the social distancing. In terms of cabin crew, we advised for this 1 to 2 meter social distancing. And so we advocated on the procedure that cabin crew must ensure that there's limited contact with passengers and their belongings as practicable, and that cabin crew are actually designated to specific sections of the aircraft, so that they do not mix with other passengers or other crew who may actually be affected. Minimizing of or non-essential functions on board an aircraft, so pre-packaging of food and bottled water and whatever needs to be provided to passengers ahead of time, so that there's minimum entry. And control of passengers when they get inside the aircraft, and leave the aircraft so that to maintain our social distancing. And of course, we reserved a specific area at the area of the aircraft to ensure that if there's a suspected case on board that present on board an aircraft, they could be managed in that particular area. Onboard management procedure that Ningland referred to has to be obviously observed at all times. On board an aircraft, social distancing is a major challenge for us. Most of the aircrafts have actually been full. So as much as we would have loved to have distance between passengers, everybody was in a hurry to actually get out of here as per the number of aircrafts that have been moving. They were full, so passengers were actually required to bring their own masks and they have to wear them throughout the journey. Frequent disinfection of the aircraft is actually required. So making sure that there's sanitization and observing hygiene at all times. While talking about sanitization, we do mention that sanitizers are actually considered to be dangerous goods, and airlines have to make sure that if they actually provide more than what is required by law in terms of the technical guidance, they have to actually contact the Civil Aviation Authority for approval. So cabin crew have to actually don the mask throughout the travel, and cabin crew has to be trained on how to manage COVID. So part of the procedure that we require from the operators is that we want to see that they've actually been trained for specifically COVID and how to actually wear PPE and other things. Social distancing, again, very important in the buses. We actually check for that. Baggage handlers and handling agents have to submit their procedures to us to tell us how they're ensuring that there's social distancing, but also disinfection of the buses. On board an aircraft, we actually recommend that crew make sure that there's social distancing and that the bedding that they share, that is on board an aircraft, that they do not share, and each member of crew is allocated their own bedding. Sanitizers have indicated that they are considered to be dangerous goods. Passengers are allowed a certain amount and crew are allowed a certain amount. However, if airlines decide to actually keep them for specifically COVID-19 and they bring more, then if they go beyond, they have to actually request approval from the Civil Aviation Authority. How waste management is actually managed: if a passenger vomits on board an aircraft, we actually advocate that the medical personnel on board manage that case and not cabin crew. And in terms of the cleaning of the bathroom, if the suspected case have actually used the bathroom, the medical personnel would actually manage that process. And otherwise, every 2 hours, the toilet has to be cleaned.
Let's say you should be winding up. Your time has run out.
Aircraft. And we look at the disinfection of the aircraft. Obviously, we basically use sanitary measures and the last slide that I'm going to talk about quickly is just your air ambulance transport system. In South Africa, we do have legislation, but we are aware that other countries do not have legislation on air ambulance. So you may actually have a fixed wing, and you may have a helicopter. And the first thing that needs to be done is that if you are bringing a patient to the country, you need pre-approval from the National Department of Health. And if it's a South African, they will be allowed if they are confirmed to have COVID. There should be no passengers on board or other patients with that patients except for the medical care team and the flight crew. The type of aircraft that you need to use, you need to consider, because you're gonna be using a flight, the aircraft incubator, which is actually on your right. You need to consider the aircraft capability, whether that incubator will be able to actually be loaded accordingly, and the doors are suitable. if there is the suspected or the confirmed case is traveling with a minor or family member, they should actually be donning PPE. Infection control measures have to be observed at all time, and the positioning of the passenger is very important, ideally closer to the exhaust of the aircraft. The isolation parameters have to be considered on board an aircraft, and if it's a long mission, PPE break for your staff, your medical crew have to be considered because it can be very uncomfortable. And disinfection, continuous disinfection of the aircraft needs to be considered. Medical ventilation of patients and specimen management need to be packaged accordingly. And if the patient actually decline, medical status decline, one needs to consider that, and if they need to be ventilated, those issues need to actually be considered. Airflow of that aircraft should also be considered, whether they actually have HEPA filters or not. Thank you very much. Okay.
Thanks a lot. I know we are doing a marathon, a race here, but the points are very valuable. We have to run to the next presentation. So now, please stay online, let's go on team, because you're, so consideration for infection prevention. Maria and colleagues, go ahead, you have the floor.
Hey, good morning, good afternoon, good evening, everybody. So my name is Maria Clara Padovesi. I will talk about some considerations for infection prevention and control in aircrafts. I would like to thank to ANSA and Laundry and also AFRO to review this presentation. So I think we have some overlapping between my presentation and the others, which I don't think is very bad, including I think it's good because some things are important to review and have very well known. So one thing I would like to introduce is some concepts that are very relevant in terms of understanding infection prevention and control concepts, because this virus is a new virus that we know, a new strain that has not been previously identified. That means that all the humanity is potentially susceptible for this virus, which creates a big challenge for infection control, although we know some experiences from other coronavirus, for example, Middle Eastern respiratory syndrome or severe acute respiratory syndrome. For this virus, what we know so far, and maybe as we are collecting more information, we can have additional information, but so far what we know is that the transmission, the primary modes of transmission are by droplets and by contact. And here it is important to say that we have both direct contact with infected people or indirect contact with surfaces in the immediate environment or objects used by an infected person. So this is an important concept because it is about the relevance of fomites. And what we know about this moment is that it seems that fomites are important in the chain of transmission, as well the direct contact with person. So we know also that the transmission is also from animals to human or human to human. And we have an average of incubation period of 5 and 6 days, but ranging from 1 to 14 days. Currently, we do not have any vaccination, so without vaccination and all the humanity being susceptible, this is the reason for this pandemic that can be explained. So current evidence suggested that the most disease is transmitted by symptomatic cases. However, are some studies pointing out the potential for transmission by pre-symptomatic people. That means people that had contact, it not have yet the symptoms, but may be able to transmit the SARS-CoV-2, which is the virus that causes COVID-19. So this is the background behind of some recommendations currently, but it's important to reinforce that what we know that the majority of cases are known by being transmitted by symptomatic persons. And in fact, the potential for transmission by asymptomatic people is quite rare, is not very well defined, because by definition, asymptomatic people should be asymptomatic for a long time. And some studies, when they go deeper, they can see that the patients, in fact, that seem to be asymptomatic, in fact, they had symptoms, but they are mild symptoms. So this is important to understand. Another information that is relevant to understand the disease is that the symptoms. So we can have fever, but it was already mentioned that for COVID-19, not all the cases have presented this fever. So fever can be presented or not. Patient can have cough, sneeze, headache. So not all the time they will have respiratory symptoms, but the majority of cases will have respiratory symptoms, and it can go from a mild presentation to a more severe presentation. So this is an important information in terms of screening people, because it's important to have training personnel knowing what kind of symptoms we are expecting this disease. So in terms of main IPC strategy, what we have as main IPC strategy that we are trying to apply for different settings, not only healthcare settings, but non-healthcare settings. First is the early recognition. As early as we can recognize an infected patient or suspected, more promptly we can install the isolation of cases, and then we can have a good source control. So this is a critical moment in which during the triage, during screening, we can try to identify as much as possible. I understood from our colleague presentation that this is not so frequent, but anyway, this is a main strategy, and of course, this is very relevant in healthcare setting, but as well in other settings. Applying standard precautions is always relevant. So, of course, this includes hand hygiene, respiratory hygiene, to be applied to all individuals or patients all the time. So this means that there are situations even if we don't know if the individual are infected or not, we will apply this anytime. And of course, when we know or if we have a suspicion of someone being infected, we should apply additional transmission-based precautions. That means contact and droplets precautions. So we have to add more PPE and more activities to try to interrupt the chain of transmission. Other things that are important are about implementing administrative control. So it's not all about using PPE, it's about to having standard operation procedures, well-defined flow of work and of activities, standard questionnaires, as already mentioned. So this is the administrative controls that should be in place. Also, some environmental and engineering controls, such as physical barriers to minimize the contact. So everything, this is an ensemble, it's a bundle of activities to avoid the transmission. So we have some guidance related to this, but also if you go to the WHO page for coronavirus, we also have IPC specific recommendations for other settings. So in terms of cleaning and disinfection, we have some important information here. First of all the cleaning personnel should be well trained. So they need to know the procedures. They need to know how to use PPE, not only how to put the PPE, but also how to remove the PPE. If symptomatic passengers are identified during or immediately after the flight. It's important to have the management of cases, which was already presented by our colleague in England, and the cleaning procedures should be followed. So service providers should wear gowns, heavy-duty gloves, face shield, goggles, and medical mask hand cleaning. I would like to highlight that it's not necessary to use coveralls. So Tyvek's coveralls are recommended for Ebola. They are not recommended for COVID. So it's important to have this in mind. So it's possible to use gauze. Of course, if they are doing cleaning in the environment, so cleaning personnel should not use medical gloves, but heavy-duty gloves. In terms of disinfectants, it was already mentioned. It's important to see the recommendation from the aircraft manufacturer, provided that disinfectant should eliminate enveloped virus. So we have different levels and different types of virus. When we talked about coronavirus, we know that this is an enveloped virus. It's not difficult to kill, but anyway, it's important that the disinfectant claimed to be effective against the enveloped virus. So there are some examples that we know from the literature. Of course, alcohol, 70%, hydrogen peroxide, and 0.56%, 0.5%, and chlorine 0.1%. So the time of exposure for these disinfectants is 1 minute, or if manufacturer have different recommendation, we need to use the manufacturer instructions. So it's what is also important is that we have the kind of relevant information to create our awareness of aviation personnel. So airport operators, airlines, and all airport personnel should have guidance for all the crew and ground staff to recognize the signs and symptoms of COVID-19 and understand the modes of transmission, what are the PPEs to be used. And among the measures, the main measures to prevent transmission of COVID-19, we already discussed about the physical distance. We know that this is a challenge, but that's why I am highlighting here the hand hygiene, because this is really, really important. Once we have the potential for contamination in the environment, hand hygiene plays a very important role. As well, the respiratory etiquette, so everybody should be trained to cover the mouth when sneezing or coughing, and also do immediately after that, do hand hygiene. Environmental cleaning is important, waste disposal, and people needed to know when and how to use a mask, how to remove a mask, and avoidance of contact with the people presenting respiratory symptoms, as the definition is we needed to have a distance of 1 meter or 2 meters. And of course—
Maria, you should be winding up. Maria, you should be winding up, please. Time is running out.
Okay, thank you. So I would say, just to finish, that be familiar with local protocols for the reporting cases, wash hands frequently, and very important, avoid touching eyes, nose, and mouth. And people, the crew should be oriented to self-monitoring themselves about potential symptoms, and of course not report to work if symptoms are present, even if mild. So this is already mentioned about the universal standard kits, which is recommended for all aircrafts. And finally, I would like to highlight that the use of medical masks should be reserved to healthcare workers and individuals with symptoms. And currently, there is not enough evidence for or against the use of masks for healthy individuals. in the wider community, but we know that some countries are recommending. So that means if the countries are recommending, we need to adopt what the countries are recommending. If non-medical masks are used, it's very important to orient people, to teach people that they should not have excessive touch on the mask and change the mask whenever it becomes wet. Wash the contaminated mask immediately after use and perform hand hygiene as well. And of course, not sharing masks. And very important is a recommendation for not using universal gloves as the purpose of infection prevention in the community. And this is meant also in the archives. And this is all for the presentation. Thank you very much.
Thank you very much, Maria. We will have a brief Q&A session before we go to the final set of questions, presentation. And I want to summarize, and please, panelists, be very brief when you are responding because we are not running out of time. In England, you have a couple that I think you need to take on. Could you tell us, maybe this is linked to your final presentation, so if it is linked, don't even talk about it. What is WHO doing to boost POE capacity? And based on the lessons learned from COVID, is there a consideration to revise the international health regulations? In terms of entry and exit screening, should we not be doing this even without outbreaks? I think that's a comment. And then there's also a comment from that COVID is seeing more cases. We're seeing more cases at screening, so we should actually continue, especially with borders with long distance drivers. Is there a specific recommended ratio for the volume of travelers and the personnel at the POE? And then Nika, how safe is social distancing in an aircraft with the same air conditioning? And please clarify the two-seat concept. What about the rows, the two-seat concept and then the rows in front and above? What measures should the employers do to ensure that the crew do not report for duty while sick? And finally, for you, Nika, is it a requirement for every aircraft to be disinfected upon landing? Lesego, how do airlines register to perform repatriation flights in South Africa? Who covers the cost of the ill traveler who is found ill on board? And why are passengers normally at the exhaust of the plane? I don't know whether that is true. And what is the other? I think that was, yeah, those are the ones I captured. What type of masks are recommended for passengers on board? Surgical, medical, N95, locally made clothes. And do passengers need to get this tested before they travel? So these are the ones I captured. Bukari, can you summarize the ones you captured? And then the panelists quickly respond to those, and we move to a final session of the presentation. Over to you.
Okay, some of the questions were repeated in the English, but there are two. One question regarding the ICAO and WHO guideline on repatriation, and what is the profile, the qualification of the staff performing the repatriation. I think this is for Lesego. And there is a practical question. What is the recommendation for airline regarding the exit procedure and the COVID-19 screening? How do they manage the check-in, the check-out, and the COVID-19 screening? Over to you.
All right, so thanks. So let's start with England very quickly, and then in the way you presented, and then panelists, please, over to you.
Okay, thanks, Ambrose, and all the participants. If this question related to whether there's a possibility or needs to revise the RHR in terms of the recommendations, I think it's perhaps it's less the question of a revision of the RHR, but more how do we gather their intelligence information and the technical expertise from different sectors, and to give a proper recommendation based on the EC deliberation, which is the emergency committee deliberation. Because I think the IHR process in terms of determining the public health emergency of international concern, and also the process of gathering the relevant expertise from different regions and also different sectors, and to put them together to convene an emergency committee, and in order to give the technical recommendations for responding to the COVID-19. I think this process is still a very valid process, and it's ongoing for 10 years. But I think in terms of the revision, perhaps it's more, how we build the technical recommendation on the evidence-based approach, which will require lots of the countries, to contribute to your practice, because the entry screening, exit screening is always very debatable issue. For exit screening, perhaps it's less difficult because it's written in the IHR Article 18. It could be part of the recommendation for with respect to person baggage, but entry screening is always very controversial because of the lack of the scientific evidence. However, we see that in the very beginning of this COVID-19 outbreak, we do have the cases detected at airports, which somehow will prevent, future cluster or cluster transmission. So it's really very case by case. We really need more scientific evidence based on the practice, based on your country's experiences. So I think that I hope I addressed this issue. So again, going back, what the main point is, I don't think that the revision of the IHR is much more needed now, because the process is still very valid. But we need more scientific evidence for each different disease, and with the evolution of the situation in terms of a technical recommendation for the world. Thank you. Back to you, Ambrose.
Nika, over to you quickly for your questions.
Yeah, thank you, Dr. Tersuma. I missed some questions, but you will remind me at the end. So, what I capture, the first one on the measure for crew to not report when ill. So what I would say is that the guidelines are developed and they will be released very shortly. But these guidelines are more focused on the current flight ongoing, meaning cargo and relief flight and so on and so forth. But it will be extended to all the crew in very short time. There is a lot of work undergoing when it comes to guidelines, specifically for the COVID-19 flight management. So same for the ICAO WHO guideline on the repatriation. So currently states are managing the repatriation based on their own guidelines, but there is work also ongoing on the harmonization of guidelines in order for states to have a clear guidance on this item too. And then a recommendation about the exit procedure. So when it comes to the operation of airlines, so in terms of check-in and so on and so forth, what I will say is that currently at the international level, the commercial traffic is not yet really, it has not yet really resumed. So maybe Dr. Ansa will cover it more in detail, but also in this aspect, there are some work that are ongoing.
All right, let's go over to you.
Okay, so there were a few questions directed to me. The first one was relating to who manages the repatriation process. It is managed by our international relations as an initiation process with the embassy, and the National Department of Health gets involved, and then the Department of Transport are the one that actually issues a permit for the repatriation for the flight to actually take place. Then the airline comes into place. The second issue was who covered the costs of the ill traveler. For these repatriation missions, everything is actually covered by the embassies so far. In terms of what types of masks you actually we recommend surgical masks. We've had a bit of challenges with availability of surgical masks, and the country have recently actually recommended that everyone basically uses cloth masks. So any form of mask is actually either surgical or cloth mask is actually accepted. There was a question on whether passengers are actually tested before. There is medical assessment, just clinical medical assessment by a medical doctor, however, not testing for COVID per se. And during that process, questions are asked as to whether they've been in contact or not. Normally, the embassies are aware because they work very closely with Department of Health of those cases that are actually positive, and those are normally not allowed to actually fly with the repatriation on a repatriation mission. In terms of the aircraft, why closer to the exhaust on board an ambulance, it's really an issue of ventilation system because you're dealing with a respiratory issue. So depending on the type of aircraft, you would consider those issues. Thank you.
Talisuna? Okay.
I was saying those are the ones I captured. I don't know whether Maria, you captured anyone in the Q&A which I missed, which you want to respond to. But in the interest of time, I wanted to move next. Okay, Maria. Yeah. Yes.
Yeah, I just wanted to add something about the masks because in the question, there was a question about the use of N95. So currently N95 it's just recommended for aerosol generating procedures. So this is not the case. So we are trying to say that this is reserved for healthcare workers when they are doing the aerosol generating procedure. So for aircrafts in general, we are thinking in dropless precaution. That means surgical mask for healthcare workers or symptomatic patients, or the use of non-medical masks for source control. So this is just to think that I would like to add, and I see that Ansa would like to add something as well. Over.
Thank you, Maria. Appreciate that. Yeah, this is Ansa from ICAO. I just have two comments to make. The one is the issue on the repatriation of COVID-19 human remains. We just published an electronic bulletin regarding that, and that was done in consultation with WHO, CDC, IATA. You will be able to find it on the CAPSCA website for now. And then I see there's been a lot of questions about disinfectants on aircraft, and I've answered some of those. So at the moment, if you use disinfectants on specific aircraft, it means it has to be compatible with the manufacturer. So the manufacturer of the aircraft has to certify that the disinfectants being used on that aircraft is compatible with the aircraft structure. Because if it's not, it could cause corrosion, it can cause problems with hydraulics. So that is really important. What we have been doing is we are in consultation with the Society of Aircraft Manufacturers. They are busy compiling a list for us on specific aircraft, which disinfectants can be used for which aircraft, like Boeing or Embraer or whatever the case might be. And that is based on the list of WHO on disinfectants that is effective against COVID-19. That list should be ready. They promised us it will be ready by the end of Thursday, because we plan to issue our first guidance on Friday, which addresses cargo operations and how to facilitate those type of operations. And that it also includes the requirements for flight crew, disinfection on the aircraft, the health measures that needs to be implemented by crew during layovers. So there's quite a bit of information on that. And finally, I don't want to take too long, like Manzi has been saying that the next part of our guidance material will be for repatriation flights and humanitarian flights. We will be adding the cabin crew member to the mix. And then that will be followed by passenger flights where we will have passengers on the aircraft as well. Thank you very much.
All right, thanks, panelists. That was really very good. I'm now going to hand over to Bukari to moderate the remaining part of the session because I have to attend another session. So Bukari, over to you.
Okay, Dr. Talisuna, thank you. I think we are going to go to the last row of presentation, and we start with presentation on IPC related to cargo by Maria and Landry.
So
Thank you.
over to Landry. Yeah.
Thank you. This is Landry. I'm going to share my screen. Can you see my screen?
Yes. Also, I want to remind the presenters that you can address most of the questions in the Q&A box so that we save time during the discussion, please. Thank you. Go ahead.
Thank you. I'm just going to say thanks to Maria Clara for helping to put together this very, very small presentation on infection prevention and control related to cargo and cruise ships trip. So one of the particularity of this kind of trip is that they gather a lot of people together for a long period of time. This kind of trip can take days, weeks, or months. So some studies have shown that respiratory diseases are the most common infections in cruise from cargo ships, and other have clearly documented that influenza outbreak on cruise and military ships and they tend to have high attack rates. Other researchers in Sydney, working in the port of Sydney, showed that in a 4-year period, 8 out of 14 outbreaks on cruise ships were caused by respiratory infections. And we saw earlier this year what's happened in the Diamond Princess ship, where more than 600 passengers and crew were tested positive for COVID-19. There is some factor that need to be considered when it comes to outbreak in during ship travel. It first the close ventilation system on board, the sharing of living quarters by persons with different levels of susceptibility. International travel can also imply climate change. But as we know, infection prevention and control can really overcome these respiratory infections, and all the measures that were described before in the previous presentations are really can be used as well as when it comes to cargo or cruise ship trip. So we need to make sure that there is a system of screening before boarding for passengers as well as for crew. And we need to make sure that the crew is trained when it comes to the management of the symptoms and signs if a passenger or a crew member present these kind of symptoms that can be suggested to COVID-19. Also, what is advice is to allocate to seafarers a single cabins, and also measures of distanciation are still applied during this long trip. We need also to make sure that there is an area where people who are presenting symptoms can be isolated from other people, and maintain the environment and hygiene and sanitation by using evidence guidance on cleaning and disinfection. So chlorine, 0.1% of chlorine can be used, as well as 70% alcohol can be used for disinfections when needed. Otherwise, routine cleaning with water and detergents like soap is recommended. There is no evidence that COVID-19 can be transmitted by goods, but it's clear that its environment hygiene should be applied. Frequent cleaning at least 2 times a day, with specific attention to high touch surfaces like door handle, light switch, etc. But also the passenger and the crew should really apply personal hygiene and avoid touching the eyes, nose, and mouth. And also the infrastructure of sanitation should be put in place, like the hand hygiene stations at all the entrances of and strategic places with soap and water or alcohol-based hand rub. And all these standard precautions that were described previously has to be applied, like waste management, respiratory hygiene, hand hygiene, etc. So there is no need actually to wear gloves when handling goods, because there is no evidence that these goods can transmit COVID-19. We just need to make sure that we are applying all the standard precautions like hand hygiene, and we can we can prevent the infection. So thank you.
Wow, thank you. Thanks a lot for this precise and concise presentation. I was looking at the Q&A, but there is no question. Let's go directly to the next presentation on IMO collaboration with WHO to address COVID. It will be delivered by Julian. Julian, over to you. Landry, can you remove your slide? Okay, thank you. Julian?
Yes. Hello?
Yes, we are hearing you. Go ahead.
Let me see. Do you see my presentation?
No.
On the screen? Just one moment.
Hey, Julian, it's Bruce. Yep, perfect.
Can you see now?
We do. Can you put it in presentation? There you go.
Now you see presentation mode?
Not quite yet. Maybe just click it one more time.
Is it now?
Bukari, are you seeing it in presentation
No,
mode?
it is not a presentation mode. It is not a presentation mode.
I don't know how to make it. Do you see enough?
Yes, I would just proceed.
Okay, sorry for that one, but I'm not familiar with Zoom. Okay, good afternoon to all, I'm calling from the International Maritime Organization, and I'm really pleased to participate in this webinar to give you some information about IMO and what we are doing with WHO in particular and with other organizations. This is an specialized agency of the UN that is mainly based, is centralized in London, and we have 5 small regional offices for coordinating regional technical cooperation activities. 3 of the regional offices are in Africa, and for different regions in Africa. This is a small organization up to 300 staff. We are responsible of standards on safety, security, and environmental protection from ships. And we also provide technical assistance to member states that focus on capacity building and human resources to assist member states to implement the instrument of IMO. I would like to raise or to highlight that we don't have operational mandate, or we don't have expertise on medical care of seafarers. This is not under our remit. Okay, do you see the next one? The next slide?
No.
Do you see now the second one?
Yes, yes.
Okay, sorry. We have a long-standing collaboration with the World Health Organization. In the last years, we are working very closely with WHO, in particular on 2 main issues. One is the amendments to the FAL Convention, that is the IMO instrument related to facilitation of... It's fine? Sorry.
Go ahead.
Is the IMO Convention on Facilitation of International Maritime Traffic is similar to the ICAO Chicago Convention Annex 9. And we are also working with WHO on providing guidance on the electronic exchange of information on the data elements related to the Maritime Declaration of Health. We are also working with WHO to develop guidance, relevant guidance for the maritime sector during the COVID pandemic. You can find in this website the central repository of all the information that we have provided and developed regarding the coronavirus. We provide technical advice to member states and maritime industry, and we do through IMO circular letters. And we also provide assistance and support for seafarers, and we have a close collaboration with the shipping industry and with the other UN agencies, as you will see later in the slides to come. In this website, there is information related to the technical advice provided to the member states. We also include the notifications we receive from member states on their restrictions and actions taken for the ships of the flags and also to the ports. And we also include the advice of WHO and press briefing and others. In the next 2 slides, you can see the instruments, the guidance we have provided to member states and industry related to the COVID. And it includes a variety of subjects, from WHO advice to guidance on what to do with the certificates of the ships, the certificate and license of the seafarers. And we have just issued today some recommendations to facilitate the change of crews from ships and airports. We have established a team in IMO to attend the seafarers' needs, and we are working closely with the ILO to provide assistance to the seafarers. And let me give you more information. We have working with the shipping industry, and we have issued guidance prepared by the industry. We are also participating actively in a strategic group established by the maritime industry to solve the problems that they are finding with the COVID, to try to minimize the impact of the COVID to the maritime industry. And we are in constant cooperation with the organizations. I would like to raise that the main concern today for the maritime industry and for the seafarers and for the international maritime organizations is the problems and restrictions for the crew exchange and repatriation of the seafarers. The seafarers can stay, according with international law, up to 1 year on board, not more. And due to the restrictions imposed by member states, they have had to extend contracts. There has been a general agreement to extend up to 2 months, but seafarers cannot stay indefinitely on board the ships, because this has an impact to their health, and also this can have an impact on the safety of the ship due to the fatigue. And this is really a main priority for the organization. To facilitate this, the disembarkation, it has been released today, this guidance to facilitate the exchange of the seafarers. And we are also working with ICAO to prepare a joint statement to facilitate the exchange of the crew. And one of the things that we need to achieve is that the seafarers are designated as key workers in the sector. And finally, this slide is the work that IMO is doing with other UN agencies. We are participating in the crisis management team established at the UN level. And we are also participating in the emergency committee of the WHO. And we are working closely with a long list of UN agencies, like ICAO, WHO, IOM, etc. And with that one, I finish my presentation. Happy to clarify any question if you have. Thank you. Over to you.
Thank you, Julian. Thank you for this presentation. We are going to go straight to the next one. It will be done by IOM on the continuity of mobility. It will be done by mobility continuum in the context of COVID-19. It will be done by Andrew. Andrew, over to you. Put on presentation mode. I think you are on mute. We are not hearing you.
Yeah, I'm just clicking on it now. Thank you so much, okay. All right, so I'll be presenting on health order mobility management in relation to COVID-19.
Andrew, go to the display setting and you choose to show only one. Click up, yes, on display. Yes, duplicate, I think.
Is it okay now?
No. Okay, it is fine. You can go ahead.
Sorry, I think my mouse is not well behaving now. after clicking on that duplication. Okay, I can't click on next from my side. I don't know what's going on.
Maybe you remove your slide and put it again.
Unfortunately, my computer's just hung.
So, and are you online, or Bruce? Can you help with his presentation?
Sorry for that.
So you can remove your slide.
Okay, are you on? Can you hear me?
Yes, I'm hearing you. Can you remove your slide and put it again?
My computer hung. I don't know. After clicking the duplicate point you had told me, it has just hung. So I can't operate it now.
Okay.
Bruce, can you try from your side? Sorry.
Hi, Andrew, is your internet and your mouse working on the computer?
You can hear that noise, I don't know.
Can you please click on the end slideshow button one? It would end it.
It has hung. I'm trying to click escape so that I do it again, but it has hung.
I think you need to switch off your computer so that Bukari can have the control of Zoom.
This is what I'm trying.
Okay.
Now I've overridden the function, so yes, Mr. Bukari, please go ahead.
Okay, it's back now. Hello? Okay, it's back now. Are you able to see it?
Hi,
Your screen is back.
we have stopped your screen share as of now. Can you reshare your screen and see if it's working?
Are you able to see it?
Okay, allow me to share my screen. Maybe it's better.
We're able to. We can see his screen now. I would just request you to go to the presentation mode. Thank you.
Hello? Hello?
Hello?
I can hear you. Please go ahead.
Andrew, can you put your screen? We are seeing your emails.
Okay.
I
think it's
okay.
Can you do it from your side? Sorry.
Landry, there was a question. Maybe you can address them while Andrew is trying to put his screen. Landry and Clara, one question was, given that the virus can survive over 72 hours, don't you think that, it is indicated to use the gloves?
Yeah, you are being cut. This is
one question, and another question, people are, participants are asking for guidance, document.
Well, may I answer the question? This is Maria Clara speaking. Yeah? I cannot hear you.
Go on, Maria Clara.
Okay, so about the gloves, this is a relevant question. The problem with gloves is that people begin to touch every places and then touch themselves and then touch other places. So instead of protecting people, gloves being used without control can create more problem than solutions. So gloves, when they are used in healthcare setting, they have very specific situations for using gloves and then changing gloves several times. And even if you are using gloves, it doesn't, it continues to require to hand hygiene. So hand hygiene can protect better than gloves in the majority of situations. So anytime gloves are recommended, it will be included in the IPC guidance. Over.
So the machine was off. Hello, are you hearing me?
Yes, Bukara, we are hearing you.
Okay, so I was saying there were two questions on IPC. The first, they were requesting, participants are requesting guidance document on IPC and COVID-19. Maybe you can refer to a link or to a website. And there was a comment that given that the virus can survive up to 72 hours on certain surfaces, don't you think that this indicates the use of gloves? Over to you.
So this is Maria Clara. I think my answer was not here, and so I will repeat, okay? So if the environment perhaps is contaminated, we are recommending cleaning. And then we are recommending also hand hygiene. So having cleaning the environment and hand hygiene is enough to control the majority of situations. But people think if they are using gloves, it can protect themselves. But what can happen is people touching several places with gloves without doing hand hygiene, and they can contaminate themselves. That's why we are not recommending gloves outside of specific situations in which we will have the specific recommendation for IPC. I will put, I saw that Landry put some dropouts, but I will put the link to the IPC recommendation as well. Over.
Okay, I've just shared a Dropbox that have some IPC recommendation by WHO, so you can consult this Dropbox. But as Maria Clara said, she will share another link for all the IPC material. Over.
Okay. Okay. And can you take over the chairing because there is no connection where I am? Ningland or Mary, can you take over the chairing?
Hello. Okay, so let's continue with the presentation. Andrew, are you ready? Andrew?
Yes, is it on now? Can you see the presentation now?
No, we can't see the screen. Your presentation is not showing on the screen.
Okay. Okay, are you able to share it from your end?
Hello, Andrew?
Mary, I'm asking if Bukere can share it from his end because I really can't tell what has happened.
Yes, I think Bukare has a problem with his internet connection.
Let me try to share the presentation.
Please.
Okay, thank you, Landry. Please
Okay.
do.
Yeah. I'm just going to open it. Okay, it's opened. Okay. And then I'm going to share my screen.
Usually you click here, and then when you click here, it comes.
Yes, put it on slideshow, Landry. We can see it on slideshow, please.
Okay, you know he's there. Okay,
please go ahead.
Landry, you can go to slide 1. Slide 1, you can go up.
Can you see my screen?
Yes, but
Yes,
you're
we
on
can
slide
see your
3.
screen.
You're on slide
Go
3.
back to the first slide.
Oh, okay.
The first slide.
The first?
Yes.
This is the first slide.
Be the first slide. Go ahead, Andrew.
Okay, fine. I think this is the old version. There was a slide 1, but basically, so we are going to look at health border mobility management in relation to COVID preparedness and response. And basically here, the HBMM model or framework looks at addressing public health along the mobility continuum. It's a framework that try to basically defines the strategic roles and looking at preventive detection and response to communicable disease. And here in communicable disease, we don't exclude any other infectious diseases as well. This framework mainly aims at trying to support the government and communities in addressing the public health threats that could be identified along the mobility corridors. And the other main objective of this is to make sure that we safeguard the global health security and looking into strengthening healthcare system along the travel corridors. HBMM try to unify 3 things. It tries to look at the border management, which most of the time is excluded in our point of entries. And then it also tried to look at the health security and combine it with the element of POE, which is quite well defined in the IHR 2005. But again, this model also helps a lot in resource allocation once you know what you need to do along the mobility corridors, and then it helps also to prioritize locations that you want to have your interventions. Next. So the framework is expanded, and it looks at the strategic objectives. We look at the core activities and some of the outcome that comes outcome out of the HBMM. Now the question here is how can we apply HBMM framework model to help in responding to COVID-19, and majorly looking into preparedness and response bit of our strategies. Now, the HBMM is based on 4 strategic objectives, and I'll try to go through one by one, emphasizing on only key points that we need to understand. And the first one is enhancing evidence-based on mobility dimension, especially looking into communicable diseases. And in the evidence-based, Teresa talked about population mobility mapping, which of us we look at it and emphasize in terms of the flow monitoring. So despite having population mobility exercise, which talks about, the population movement in general, we link it on the third stage to make sure that we have evidence of and the mode of transport, etc., that they have used to move. It also defines as some of the assessments so that you make sure that you have some key reference points to your strategies, and for sure looks into the disease surveillance, which WHO colleagues mentioned about. Also look at reporting and information sharing, which I will emphasize on as we continue. The second of strategic objectives looks into health system strengthening, and this includes provision of infrastructure. And again, I want to say that this is mainly on the mobility corridors, looking into prevention and infection control, vaccination. We'll be talking about those who are traveling must be vaccinated. Right now, it's those who are traveling must that. Screening and referrals, basically at the point of entry. But again, in terms of laboratory strengthening, and this is also a discussion that is currently going on, the of testing at the point of entries. In most cases, that doesn't happen. But again, based on the different capacities of different countries, and IOM has that kind of a bigger capacity in many of the countries, and I'll talk about the last slides. We need to look into building the capacity in terms of laboratory testing. The third one is engaging and empowering populations in making sure that the population understands the risks of their traveling, the community engagement, especially looking into maybe the truck drivers, the airport taxi association, and sitting with them, engaging them on the risks and how we mitigate some of the risk. Then the last thing over there is mental health and which often it's also coming as a key thing that we need to incorporate in our country. The last strategic objective of this HBMM framework looks into how we can promote sensitive policies and regulations. And this, we're looking into a development of some legal framework or operational framework, or into policy help to make sure that our implementation of activities are quite. And again, now those about the truck drivers, I'll use that again as an example. We have been discussing on how to develop a framework that will help us to make sure that we mitigate the kind of spread of the fact that truck drivers are moving from one country to the other. These are the four strategic objectives, some of the activities that are aligned to it, which may be very, very useful as we implement the COVID-19 response. I don't want to go into the outcome, but just to highlight that there are the main intention of this is to make sure that we have public concerns along mobility corridor. Next. Now, on this slide, I will just choose a few lines because the other colleagues also talked strongly about it. That was Teresa. Now, how can these framework help us in response to COVID-19? I guess that will be the question for everyone. And as mentioned, I just want to stress that strengthening point of entries is key, and we have seen a number of point of entries operating with different countries, despite the fact that IHR provides a guideline on what needs to be done at the point of entry. So, unless the contact tracing is a key element which has been included from the departure.
Try to stay near your micro, please. When you are moving, we are losing you.
Okay, sorry. So go back. Yeah. So strengthening the point of entry and washing, including biodata and contract tracing, which is a key element in the point of entries. Often we look at point of entry as a temperature check, and I think most of us has always seen point of entry as, you know, using a thermometer and all that. But I think based on the experiences we have seen from the Ebola in West Africa and from the ongoing Ebola in DRC, we can do a lot at the point of entries and make sure that we address a lot of issues comprehensively that can support the point of entry. Then the other thing is that analyzing mobility trends and the PMM. In a PMM, we try a lot to make sure that flow monitoring is a final element that is considered when we are providing support. Right now, with the lockdown, we know that people are not moving from one country to the other. But again, there are unofficial point of entries that has come up from that people are using and avoiding the ones where the government has put security to man and all that. And the population mobility mapping will be very, very important to help understand and to put some of the control measures and risk communication activities at those points. Then in terms of capacity building, which this framework offers us, and as I mentioned earlier on, that we try to make sure that our response and the training that we offer, we include the migration officers, not only the health team at the Port Health, but we also include the migration officers who will be able to support in terms of contact tracing and also in terms of identification of cases. And looking into this, we also talk about development of some SOP that is aligned not only to health, but aligned also to the migration officers and how they can be able to support the activities at the point of entry. And this goes as basic as also the basic first aid and IPC activities that are supposed to happen. Then finally, on this slide, looking at the cross-border collaboration and surveillance, especially the frameworks that I talked about in the previous slide and roadmap to make sure that there is an agreement within the region and whatever is being implemented within the region is consented to by the member state. I know that is one of the difficult parts. Next.
1 minute, please.
Next. Yeah, next slide.
1 minute.
So this slide, the last two slides, I will just summarize them. It talks about mainly emphasize on capacities and restructuring of resources that we have. Some of you might know that IOM has a migration health assessment unit as part of health unit that does a lot of work in terms of making sure that the health condition of those who are traveling are safe and also providing continuity of care before the traveler departs the destination, and making sure that as they travel and as they reach their destination, they are well taken care of. We also do a fit to travel test, which is in form of making sure that the travelers are safe before they travel. And finally, looking into the main thing of doing all this is to minimize and mitigate the public health and public safety risks that are related to mobility. Next. So next. Yeah, so this just shows the capacities within the different continents. Apparently having, like this is the data for 2019. In sub-Saharan Africa, which will be more interesting, we did health assessment to 140,000. We are present in 80 countries and 35 countries in Southern and sub-Saharan Africa. Next. And the main activities that we involve as are listed below, including chest X-ray and all that. And now here we have decided to divide some of our capacities within the country to make sure that they support the COVID-19 response. And that includes the presence of the gene experts in a number of countries, 9 countries at the moment in Southern and Sub-Saharan Africa, but also looking into the health staff that we have all over different countries, and apparently the health staff that we have are supporting quarantine, isolation, case management in different countries. Basically in Kenya, we sent about 40 plus health staff that are currently supporting in quarantine areas. Thank you.
Okay, I'm back.
Okay, welcome back, Bukare. Go ahead, please.
Thank you for supporting Landry and Mary. Thank you, Andrew. We are now left with last presentation by Ningland to show the resource available at WHO. Ningland, over to you.
Thank you, Bukari and all. And I don't, let me check. I guess I have a problem also finding the right presentation. I'm sorry again for the hiccup. Yes, I can't share the screen. I don't know what happened. It's not moving. Okay. Yes. Yes, exactly. Okay, that's great. Please use this.
Okay, can you go ahead?
Yeah, thank you. So just very quickly walk you through the available guidance for points of entry. So in the WHO COVID-19 website, you see different boxes. And so there is a box for points of entry where all the COVID-19 related points of entry guidance are archived. Next slide, please. I wouldn't go down to the details, the nitty-gritties that we already discussed. So the main guidance for points of entry, one is the management of air travelers at all different points of entry we just introduced. Next slide, please. And onboard management of COVID-19 aviation, we also did our very briefing overview. Next slide, please. Under operational consideration for managing COVID-19 cases and outbreaks on board ships. So this was also developed in the very beginning of the outbreak. And it was developed in consultation with our maritime sector. Julian was very supportive on getting the consultation review from the shipping industries. So these are, next slide, please. Yeah. Also, we have issued a joint statement with International Maritime Organization, International Labour Organization, related to the seafarer issues and also the ship sanitation certificates under the IHR, because there's a many difficulties that the ships have encountered because they have outdated the ship sanitation certificates and they couldn't get the renewed because of many ports are shut down. So the ships sometimes got quarantined or get fined. So to cope with this situation, we have issued these extraordinary and temporary measures for the ship sanitation certificates, where you can also find it in this POE portal. Next slide, please. There's an ongoing guidance for the ground crossings, because I see some of the questions were asking, we're missing this land border guidance. So this is also related to what Teresa has introduced for the population movement mapping, because the land border, we have the designated points of entry, the ground crossing, but we also have really unsupervised ground crossings. So this guidance will address different types of ground crossings using the population movement mapping as a base to identify priority ground crossings, and then we give you our checklist to identify the activities for different types of ground crossings, and perhaps the train stations and also the communities nearby the ground crossings, and for your preparedness and response in the context of COVID-19. Next slide, please. Okay, so we have also published our generic handbook for public health capacity building and ground crossing and cross-border collaborations. So part of the COVID-19 specific ground crossing guidance actually are derived from the principles in this handbook. So just give you our info on that. Next slide, please. In terms of online interactive courses, so the current 3 published COVID-19 guidance, POE guidance, have all been converted to this online interactive course. So this is a course that we're trying to stimulate your thoughts, and through the scenarios, questions, text reading, and to really to help you warm up the knowledge that you got from the guidances. So each course normally it takes like 1 hour, and it gives you the scenario, really asks you to go through the different scenarios, answer the questions, which is based on the knowledge delivered by the courses. So I really encourage you to go through these 3 courses that in our website. Next slide, please. So this is the management of air travelers. So this is the web link for this course. It's free and no need to sign for account. So just free for use and free for dissemination to your colleagues, and to get you familiarized the air travelers at points of entry, how to deal with that, how to make the medical transfer, how to do the cleaning and disinfection on the contaminated environment, and so on and so forth. So this is this course. Next slide, please. And this one is the operational consideration for management of air COVID-19 outbreak in aviation. So that was basically, again, converted from the guidance in the similar title. So yeah, this also is the similar way of the other guidance, other online courses. So you have the features, you have the case scenarios, and also the quizzes. Next slide, please. Yeah, this is another course for onboard ships, case management onboard ships. So all these 3 courses, you can find the different web links. When you receive the slides, you can go straight to the web link and to start to navigate all these courses. Next slide, please. Last but not the least is the generic public health event management in air transport e-learning course. This is also developed with the support of ICAO. ANSA has made a lot of contributions to this course. So you will see this is the modules. We have a module for RHR. Next slide, please. And here is the different episode for the public health measures for travelers. So these are just the examples. So we have several modules. Each module contains different topics. So these are just the example, just to give you a sense, you know, how that online course is presented. Next slide, please. Just to give more flavor to this online course, so we also designed the notes from the field, meaning really these are the remarks, these are the experience that we coded from the field workers. So you will see that for different type of measures that there's some field feedback. So just to give a sense of how the public health measures can be implemented at on the ground. Next slide, please. This is what we call the 3-MAT challenge. Actually, is a scenario for you to work through, use the knowledge that you got from the online courses and to work through that, and then to answer the questions. And in the end, we will give you the suggestive answers for you to reflect on your own judgment and answers. Next slide, please. Then we have a final quiz. It's 15 quizzes for this course. And then you got your course assessment. So once you pass the assessment, you will get a certificate of completion. So meaning you successfully completed this course. Yeah. Next slide. I think that's all for now. It's the online resources for you for your free use, and please just disseminate as much as you want. Thank you.
Okay, thanks a lot, Ninglan. I could not follow the Q&A, but we have passed the time more than 30 minutes. What I would propose, we have the question asked. We are going to address them, and when we are sending the slide and the recording, we will attach the response to the question so that we don't keep participants waiting for long hours. Because of the Ramadan, I'm sure that some people in some country are preparing to break the fasting now. If you don't have any other opposite point of view. Before we close, I don't know if there is a burning issue, Mary, Ningland, or any other presenter, if you want to say a word before we close.
Thank you, Bukhari and Ambrose and Mary and all the panelists and the audience. This is the first regional POE training, and I think this gathered a lot of experience for us to roll out to the other regions. So thank you very much. And yeah, if you can share the questions from the Q&A, and we will try as much as possible to respond. Thank you, Uber.
Okay, thank you. IKEO, OMI. Yes,
thank
go ahead.
you, Dr. Bukhari, and thank you for the participation. So we are, as I said, we are available through our regional offices to continue supporting state in the implementation of IHR requirement and IKO requirement, well, with regard with the COVID-19. So we will be continue working together, and I would like to thank you again for inviting us to join this seminar.
Thank you. Any other? Okay, I don't see another person. Lesego, you're not online. Thanks a lot. I think this brings the end to this session. The objective was to provide clear guidance to country, member states, in the context of the reopening of the border, alleviation of the confinement measure. Lesego, you want to say a word? You are on mute.
Thank you very much for the opportunity.
Okay, thanks very much for the opportunity. Thank you. So as you can see from the various presentations, we need to work together to anticipate the reopening of the border and the alleviation of the confinement measure. We need to have a multi-sectoral, multidisciplinary approach in a spirit of partnership and solidarity, and we need to pay attention to details. This is very important. We need to pay attention to details in order to protect the travelers, the passengers, and the staff working at the different point of entry. I want to thank again all the presenters. We know that you took a lot of time from your time to prepare the presentations and to participate to the training. Thanks a lot. We appreciate your effort. I would like also to say a big thanks to the participants. You were more than 400 connection participants to this training, and we can see the interest, a lot of questions, a lot of pertinent questions. So thanks a lot for your participation, for your patience, despite some technical issue. Thanks a lot to ECHO, the University of New Mexico. Bruce, are you online? Thanks a lot, Soam, for your support, your technical support. We confirm that the recording and the slide will be sent to all attendees who registered. You will receive it in 2 days, 2 or 3 days. You will have it on your emails, along with the response to the remaining questions. Thanks a lot to the interpreters. They are working, as we say in French, ils travaillent à l'ombre. We are not seeing them, but
dans l'ombre, nous les voyons pas, mais ils sont là, ils travaillent.
To support us and to ensure that the training goes well in the 3 languages. So thanks a lot to the interpreters. Thanks a lot, everyone. This is the end of this session, and see you next time.
Thank you. Bye-bye.